We're gonna need a table for this event. They're only being used. Right.
Put those up. Put them somewhere. Great. Good?
Yes.
Okay, we're going to get started soon. If you haven't yet, you should download this Slido app for the audience response questions. How do I get to the introduction slides?
No, basically, the only thing was the fingers like this.
Okay, great.
And then you go to the next one.
Just like this, right? Okay.
That's fine. So you can either click or
All set? Great. Good morning, everybody. We are live on YouTube, live from New York. It's our 7th annual MonteHeart Symposium. We have over 300 people registered to be here. So I think eventually you leave your jacket on your seat. So audio is not on.
Can you turn off the volume?
Okay. Thank you. I can maybe get closer. Is it me like this? That's better, right? Yes?
Yes.
Okay, everybody can hear. Most people can hear. Very good. So welcome again to the 7th annual MonteHeart Symposium. We have a really nice 2-day program for you. I do want to acknowledge the unrestricted educational grants from Abbott, Abiomed, and Bristol Myers Squibb. I can tell you that throughout and after the COVID epidemic, it's been extremely difficult to get funding for conferences like this from companies. So we're really very grateful for these 3 companies to support us. This conference cost a lot of money, and we are in the clear for that. There also is an exhibit hall outside. I'm just going to read this list. Abiomed, Alnylam, Ancora Heart, Artivion, AstraZeneca, Baxter, Bayer, Bristol Myers Squibb, CareDx, Daiichi Sankyo, Kiniksa, Medtronic, Merck, Novartis, Pfizer, Philips, Transmedics, and Zoll, as well as Paragonix and Abbott are exhibiting out there. So please take a look at what they have. In terms of CME credits, they're up to 12.25 credits for physicians, also for nurses. These are special credits. You have to apply for every category. So both nurses and physicians can claim full credits for this conference. Thank you for attending also. After the conference, we will send out an email with an evaluation link. That's very important for us, A, to make it better, and B, for the CME process. So you don't have to write a whole lot, but just be brief. And if it's something negative, that usually goes the longest way. Everything was great. We really appreciate, but it's more, what can be better? Please also write everything was great. All other attendees will need to sign into this link where we post the code also later. 43FISH is the code if you want to get CME credits online. Again, very important. We're going to have audience response questions throughout the conference. You can scan this QR code, or you can go manually into this website. You can download the app Slido, which is, I think, the best way, just from the App Store. And then the questions will come up as we go, if you have it on your iPhone or other phone. Great. And then other than the audience response questions, just don't use your cell phone inside here other than to tweet wildly. I do want to thank everybody who helped setting this up. Stacy Atkinson from CME and her team, Gabriella Besnick from my office, and Clyde, who has become an audiovisual expert, who's going to hopefully start his residency here soon, and just everybody who helped with the planning. So with that, I'm going to ask Ankla to help me with this. We'll introduce the first speaker, and then Julia, Catherine, Marie, you should be where your name tags are as a panel. And then the first speaker will be Marie Galveo. And Marie and I go back to my fellowship in the last century, 96 to 99. We were both at Einstein, and I was a heart failure fellow, and Marie was a heart failure NP. And Marie has really risen to national prominence in heart failure. I think one of the original heart failure NPs. Really doesn't need us to manage heart failure, but we pretend that sometimes we advise her. Usually I ask her what to do. So I look forward to the first presentation about GDMT and HFrEF. Don't go home without it.
All right, good morning, everyone. So probably I could just stop here with this slide, quite honestly. GDMT, heart failure, reduced CF. Don't go home without it. Don't leave the hospital without it. Don't leave your office without it. That's really the key message that I'm going to speak to today. Now, I know it's early. The crowd's still a little thin, but we're going to start off with a question. Well, maybe not.
Ankla's going to help you.
I did my 3-finger. Oh, there it goes. All right, so I'll explain the scenario. We have 2 patients, Jack and Jacob. You're going to have to trust me when I tell you that they are clinically equal. So 55 years old, reduced EF. Let's just say for all intents and purposes, they're equal patients. Jack is on enalapril 10 milligrams BID and carvedilol 25 milligrams BID. Jacob is on sacubitril valsartan 4951 BID, carvedilol 25 milligrams BID, spironolactone 25 milligrams daily, and DAPA 10 milligrams daily. So the question for you all is, how many additional years might we expect Jacob to survive versus Jack? None, about 1.5 to 2.5 years, 3 to 5 years, or about 6 to 7 years. Audience response.
We've got about 30 hits.
30 hits, all right.
And
I'm not sure what triggers the actual. Oh yeah, 35, okay. All right, so it looks like 3 to 5 years is winning here. We're gonna get back to the answer for that in a few minutes. All right, so what's new in GDMT for heart failure reduced CF? The truth is, what's new is not really a new drug. What's new in 2024 is really the focus on how we implement the therapies that we have, how we titrate them, and how we sustain those therapies. So I'm sure you're probably familiar with the 2022 most recent guidelines for heart failure reduced DF. If you haven't already, this 6-step process for the management of heart failure is actually quite nice. So we have a patient with diagnosed with heart failure reduced DF. In all likelihood, you're going to have to start off decongesting that patient, and then you're going to implement guideline therapy. So the pillars, the 4 pillars for heart failure with reduced EF: ACE, ARB, ARNI. ARNI's preferable. 1 of 3 evidence-based beta blockers, a mineralocorticoid receptor antagonist, and SGLT inhibitor. Over the initial weeks, you're going to optimize the doses of those therapies. After a few months on optimal therapy, you're going to reassess that patient clinically, and you're going to reassess ejection fraction. If they have continued depressed EF, you're going to assess their eligibility for an ICD or CRTD. African-American patients with advanced heart failure, you're going to put them on hydralazine and isosorbide dinitrate. And then we have a variety of other therapies that we're going to consider, and I'll get back to those a little bit later. If you end up with a patient that really has advanced heart failure, refractory failure, then we're going to consider advanced therapies, which you are going to hear quite a lot about for the rest of today. So I'm not going to get in that any discussion about that. So stay tuned for more later on today. You may have seen this slide before. I've updated it, but I'm showing it again really to focus on the evolution and the timing of these therapies in heart failure, because for years now, this has dictated how and when we initiate therapies, optimize them, and move on to the next. So, you know, way back in the 80s, ACE inhibitors were the first drugs to be approved with significant efficacy in heart failure. We initiated ACE, we optimized it. A few years later, beta blockers got approved. We took our patients on optimal ACE, and then we titrated beta blocker, and then MRAs, and so on. So we went down this chronological path of adding these drugs in that order, optimizing one and then adding another. That has changed, and that's what I'm going to chat about in a little bit. Also, what's very new or relatively new, the last of the 1A indications for heart failure, SGLT inhibitors. So you've heard a lot from us in the past about dapagliflozin, empagliflozin, both very efficacious in reducing cardiovascular death and heart failure hospitalizations, particularly heart failure hospitalizations. Now we have a third SGLT 1 and 2 inhibitor, which is sotagliflozin, studied in a little bit of a different patient population with worsening heart failure, but also now approved with an indication for heart failure across all EFs. Re-emphasizing the guidelines, the pillar therapy, you'll hear constantly pillar, pillar, pillar. These are the 4 1A therapies. Again, ARNI, ACE or ARB, ARNI preferred, evidence-based beta blocker, MRA, SGL inhibitor. Again, keep in mind that if you have a patient that's African-American with advanced heart failure, hydralazine and isosorbide dinitrate is also a 1A therapy that should not be left off. What about additional therapies? So you may think, okay, I'm already dealing with 5 therapies, 4 therapies. Now I have to add more. And the answer is possibly yes. So if you're ACE, ARB, or ARNI intolerant, you're going to add isosorbide dinitrate and hydralazine. Digoxin we use less of now, low margin of safety, but it does still have a role. Ivabradine is the only sinus node inhibitor approved. It can be used for patients that are in sinus rhythm, maintaining heart rates above 70, to be added on top of a optimally titrated beta blocker. You don't use this in lieu of a beta blocker. There is a correlation between higher heart rates and worsening outcomes for heart failure. And in the SHIFT trial, the drug was notable for reducing heart failure hospitalizations. Vericiguat is a soluble guanylate cyclase stimulator, increases cyclic GMP. It was studied in a heart failure population that was recently with acute decompensated heart failure in the hospital, also shown to reduce heart failure hospitalizations and CV mortality, although again, more effect on hospitalizations. We have quote unquote newer potassium binders, which are better tolerated now and can facilitate the introduction and the optimization of RAS inhibitors in patients that are hyperkalemic. We're short on outcomes data with these drugs, but there is evidence to show that we can safely use them in combination with RAS inhibitors, titrate our patients, and maintain lower potassium levels. And then in addition, we do see a lot of iron deficient anemia in heart failure. Oral iron therapy has really not proven to be efficacious, but IV has in regards to improving functional status and quality of life. So IV iron now is approved for the use in class 2 to 3 heart failure patients. I will say we have a really nice process here at Monte within EPIC, thanks to our hematology department. If you have an iron deficient patient, just ask for e-iron consult. They will take it from there. They'll assess your patient and they'll implement therapy if it's indicated. Very smooth process. Enough cannot be said about the magnitude of the benefits of these core pillar therapies. You can see here the reduction in mortality and in heart failure hospitalizations that have come as a result of each and every one of these therapies and the combination of these therapies. So we cannot deprive patients the benefits of these therapies. Now, you might look at them and say, great, we've done so much here, you know, we can rest a little bit, but unfortunately not entirely the case, because heart failure still remains a very complex, morbid, and mortal syndrome. As you can see here, patients admitted for heart failure 5 years out have a 75% mortality rate across ejection fractions. So as much as we've done, we still have more to do, but we can at least start with just giving patients the drugs that are already out there, because there's way too much underutilization of those therapies. So getting back to our patients, Jacob and Jack. So this is a cross-sectional analysis, an estimate of treatment effect in heart failure reduced EF, comparing 3 trials, Efficacy-HF, DAPA, and Paradigm-HF. And you can see the gains from comprehensive disease management, which Jacob had, versus conventional therapy with dual therapy, which Jack had. So Jacob, fortunately, is living here on the left of the line of unity, enjoying quite a lot of benefits as opposed to Jack, and his estimated additional survival could be beyond 6 years. So make sure when you're treating your patients, you line them up behind the Jacob queue. All right, so you've heard forever our preaching that we have to use more guideline therapy, we're underutilizing therapy, and quite honestly, we've been preaching this since the 80s. But it's true, and it's unfortunately still true today. Evolution-HF is an observational study that looked at over 250,000 patients across 3 countries with the goal of observing patients from the initiation of guideline therapy out through over a year. And in conclusion, it showed that titration of drugs was too slow, too few patients got to optimal therapy dosing, and there was early discontinuation. If you only focus in red here, you can see that the discontinuation rates are ridiculously high. So dapagliflozin and Entresto are 1/4 of patients off after a year. MRAs, almost half the patients. Quite unacceptable, unacceptably high discontinuation rates, and our initiation is just not effective enough and efficient enough. Even in patients that improve their ejection fraction and improve LV function, we cannot withdraw therapy. So TREAD-HF is a small but very pertinent pilot study, which included a little over 51 patients that improved their ejection fractions. You can see the criteria here blocked out. Randomized to either stay on those therapies or have a staggered withdrawal of therapies. Primary endpoint being relapse of dilated cardiomyopathy within 6 months. The criteria of which are as noted here. So either a fall in EF, an increase in LV and diastolic volume, or increase in NT-proBNP, clinical heart failure. Within 6 months, 44% of those patients suffered a relapse of LV function. And in the following 6 months, an additional 9 patients met criteria. So 4/5 of those patients had a relapse in LV systolic dysfunction with withdrawal of therapy. So whether you're still maintaining a good EF or not, you cannot withdraw guideline therapies in these patients. So getting back to the guidelines, as I mentioned, the message here is how are we changing in the way we implement and optimize therapies. Simultaneous initiation or sequencing should be individualized to the patient. So, you know, one clinical scenario is different from another, one patient's different from another. The way you implement those therapies could be different from one patient to the next. There's not one complete algorithm you're going to follow. But the point being is you no longer need to follow that sequence of trials that I showed you in the second slide. We no longer have to optimize an ACE and then add a beta blocker and go in that direction. You should implement 4 therapies, quad therapies, as early as possible, and then you want to titrate them as efficiently and as quickly as possible. So the guidelines really communicate an urgency here. And the reason for that is that if you look at ARNIs or MRAs or beta blockers or SGLT2 inhibitors, the effect of these therapies is very early on. So you can go back decades to the Copernicus trial, which was a study that looked at patients with advanced heart failure. And within 8 weeks, there was significant mortality reduction on the beta blocker carvedilol. In the EMPA-REDUCE trial, there was a statistically significant 58% relative risk reduction in death, heart failure hospitalizations, or urgent heart failure visits within 12 days of the initiation of therapies. So this is why there's an urgent message. Get these drugs on board early and titrate quickly. Now, for those of you who are in the trenches actually initiating and optimizing these therapies, you may say, okay, well, that's easier said than done. And I would not disagree with you. But we know that we can do this and we can do it efficiently and safely. STRONG-HF was a trial that took a little over 1,000 patients in the hospital with acute decompensated heart failure. Patients were randomized to usual care or high intensity implementation and titration of these therapies. So before these patients left the hospital, they were half titrated on therapy. They left the hospital, and then very early on in the initial weeks, that titration was completed. The primary endpoint was at 180 days of all-cause death or heart failure readmission. You can see here a significant reduction in events in the high-intensity group, primarily led by a reduction in heart failure readmission. Now, you may ask, okay, at what cost? And it is true. Side effects were greater in the high-intensity group. Greater percentage of patients with hypotension, hyperkalemia, and renal impairment. But the serious adverse events were no different between groups. The fatal adverse events, no different between groups. Change in GFR, not statistically different. And the patients that were in the high intensity group had 33% lower NT-proBNP levels. So I'm not telling you that it doesn't require a lot of work. It does. It requires a lot of perseverance, but this can be done, and it can be done safely. So I'm just going to finish up by saying, think about the risk of omission. You have to offer your patients these therapies, or they will suffer the negative effects of reduced survival, increased hospitalizations, worse quality of life, and worse symptoms. So to take a quote here from Steve Green from Duke and his colleagues in this 2023 JACC publication on worsening heart failure, there is strong evidence to support simultaneous or rapid optimization of quad therapy. Yet there is no evidence that routinely delaying initiation of quad therapy accomplishes anything beneficial. So thanks for your attention. And I don't know if we're going to do Q&A now or just on the panel. But I can take some questions. Yes.
So in clinic, what type of measures are available to you in terms of patients who perhaps insurance might be resistant to approve certain medications, which then incurs a very costly patient?
Yeah, so we come across this with two therapies, right? With sacubitril/valsartan and with the SGLT inhibitors, unfortunately. Sacubitril/valsartan has gotten a lot easier. So first and foremost, when you put an order in Epic for, if you're using the MonteEpic system, if you put an order in for any of those drugs, they usually require a prior authorization. And there are pharmacy specialists now that sort of intercept your order and will work to get that authorization for you. So that's a big plus. In our office, we also have heart failure nurses that help to process those authorizations if needed. If patients have private insurance, we can use copay cards. So if we advise our patients to go online, download a copay card, which really mitigates the cost. If they don't have that option, if they're Medicaid or Medicare, they're not going to be eligible for that. We also advise them and we assist them with this. Our industry folks, so the makers of these therapies, do offer free drug to patients that are financially in need. They just need to fill out an application to see if they're eligible for that. And usually we have to help them with that. It's really not that hard to do, but many patients are eligible to get usually a year's worth of therapy for free, and then they have to reapply to maintain that service. I won't tell you it's 100%. Unfortunately, it's not. So for a patient that can't get an ARNI, for example, then we'll put them on an ACE or an ARB. But unfortunately for SGLT2 inhibitors, we have no other options, right? Dapagliflozin is actually available generically now, but our experience thus far is that it's very hard to get. So no one seems to have it, but hopefully that should be available sooner than later. But I appreciate your comment and the fact that we do run into challenges with, getting patient access to these therapies. Other questions?
I have a question.
Yeah, sure.
I have a question. When you start, so Entresto and SGLT2 inhibitors have that diuretic effect.
Yep.
And so when you start both on the patient and the patient is also on the weak diuretic, what are you doing with the weak diuretic?
Yeah. So, yeah, sure. So Dr. Shin was asking a really good question, which is, so both SGLT2 inhibitors and ARNIs have a natural diuretic and natriuresis effect. So her question was, what do we concurrently do with a loop diuretic when we introduce those therapies? So again, look at your patient individually. If your patient's fluid overloaded, then you may not do anything with that loop diuretic. But if they have a low diuretic requirement, and particularly patients that have marginal blood pressures, we will concurrently reduce the dose to some degree of that loop diuretic. And then as we titrate the ARNI, for example, we may even stop it. I can actually just give you a quick, so here's three different patient scenarios, because again, you have to look at patients individually. So if you look at this first patient, for example, this is a person that's on 40 of furosemide a day, newly diagnosed non-ischemic cardiomyopathy with a relatively solid blood pressure, good kidney function, and a BNP of 460. So he's not dry. This is the ideal patient where you probably can introduce all four therapies concurrently. But if you notice on the side in blue here, I noted reduced furosemide, because the likelihood is he's going to require less loop diuretic at that time. Now, as I'm going up on the ARNI, I may just switch that diuretic to a PRN only. So, you have to look at that patient in one view. Now, the next patient is a much more challenging patient. This patient's class 3. He's on only furosemide every other day, a marginal blood pressure, renal function's not good, and his BNP is not particularly high. So we're not going to have a lot of room in this patient. So in this patient, I opted not to add an ARNI and SGLT2 inhibitor at the same time. I started with the SGLT2 inhibitor, and then as I was introducing the ARNI, I completely stopped the furosemide, added the ARNI, and then went forward. We may not get that patient to optimal ARNI therapy, we may, but I've gotten drugs on board, and it's going to take a little longer in this patient than in this patient. So this patient can be titrated to optimal doses of everything in 4 weeks. The next patient with a marginal blood pressure, marginal kidney function, and a BNP of 100, I may not get to a full dose of an ARNI. I may or may not get to quite a full dose of beta blocker, but I'm going to get all those therapies on board. It just may take me a little bit longer. So, and then you have another case here, which is entirely different. So you've got to look at the patient individually. And absolutely, when you're introducing an ARNI or an SGLT2 inhibitor, anticipate your patient's going to lose some volume just from those drugs alone, and you may need to reduce diuretic. I think, unfortunately, many patients get labeled as being intolerant to a therapy when they're not, for just this reason. Patient number 2 here, nobody reduces their diuretic, they get hypotensive, they get taken off drug, and they get labeled in the chart, ARNI, SGLT2, intolerant. And you're doing your patient, who, quote unquote, is Jack, in my scenario, a gross disservice. So really good point.
Yeah.
Quick question, Marie. For a long time, we've been talking about, even just from beta blocker and ACE inhibitors, how we're not getting enough people on drug with the target doses, and the evolution trial that you showed is still the same thing, with even more drugs.
Yep.
So what should we do differently besides just bringing alert to everybody? I kind of have an idea, and my thought is that maybe the most important thing that the strong heart failure trial showed us was that an up titration when it works.
Yeah.
Is that what we need?
Yeah. So, and I'll tell you, and maybe there are folks in the audience here. We get referrals from cardiologists who have clearly the ability to manage heart failure themselves, but they refer them to us because they don't have the time to really focus on what it takes to really optimize these therapies. So we get patients referred to us that could be managed by their own cardiologists, and they just say, quite frankly, can you just take care of this? Like, I don't have time for this. I can't focus on this. And that's what happens. They'll refer their patients. In our clinic, we have a lot of bodies on board, including NPs, heart failure nurses, and physicians who can all engage in managing what it takes to optimize these therapies, to recheck labs, to tweak the medicines, and then to get them through the bumps in the road. So, titration clinics have been are more and more popular, I think, even within general cardiology practices. So that's a really good point to be made. I'm sorry. Yes, question.
I totally agree with what you say. I mean, Joe Gonzalez in Spain, we published an ethical trial, which was published in 2021. We randomized 320 heart failure patients to up titration by heart failure nurses in 4 months versus up titration by heart failure cardiologists. And guess who got the highest dose of beta blockers?
Okay, I'm just
The nursing.
yeah. I think first of all, physicians have their time is spent doing so many other things, right? You're in the cath lab, so in all honesty, they're doing different things that we in the clinics are not doing, and we have the time to really focus on that. So I'm not suggesting that, we have great heart failure docs here that are equally capable, but they just have less time sometimes than we are. But nurses are very, really persevere.
Yeah, I'm going to disagree. One time, I actually wrote it down for myself. The big message in the beginning was if you send the patient home. I'm saying this because I see a lot of our CP nurses going home. If you and the patient with heart failure for the first time, 60 years old, like that can take off, and you give them an ACE and a beta blocker like 10 years ago, and you send them home, and whoever is taking care of them after has your skill set, you shortchange the patient 5 years of life in the long run. So if you're the nurse, don't be like Marie, don't be nice. Tell the doctor that's sending the patient home, why is this patient going home on this regimen? You should feel free to do that. That would be really appreciated. And if they're really that busy, they just want to say thank you, which they should. I have a question over it. I get that, the providers don't put the patient on drug for many reasons, but I don't understand this incredible discontinuation rate.
Yeah.
In my practice with my patients,
you don't see that. Yeah.
I don't see that.
Yeah, I think a lot of that comes about when patients get marginally hyperkalemic, instead of trying to work to treat that or reduce doses, people get taken off, right? I think a lot of it comes down to the time and effort you put into that patient. A lot quicker to just take them off an MRA than to really work to keep them on it, right? The other thing is, patients live lives. Things happen all the time that will cause them to be at one point to potentially be transiently intolerant. So we have patients that are really sick. We fight like hell to get them on optimal therapy. 6 months down the line, I just recently had a patient. He was on good therapy. This guy's been living, walking on, eggshells, trying to keep this guy stable for years now. And he got a gastroenteritis. He got volume depleted. He was in JFK Airport, passed out, went to the hospital locally, came to me on nothing but 3.125 milligrams of BID of carvedilol after being on optimal therapy, including a Vericiguat. I just wanted to scream. it's going to happen, and patients have to come off therapy sometime if they get dry, for example. So people will get a gastroenteritis or whatever. The problem is that effort to get them back on is often not there. So I think, or patients often come in with marginal blood pressures, but they're asymptomatic. If a patient comes to us with a blood pressure of 92 and they're feeling fine, we don't even pay attention to it. We don't even ask those patients to check their blood pressures at home. But other providers might get a little anxious about the fact that their patients are walking around with a blood pressure of 90. So I think low blood pressure, hyperkalemia, volume depletion, there's a lot of things that can happen in these patients day to day, week to week, that at some point are going to make them less tolerant to therapy. And if you don't persevere and put the time and effort into getting them back on those therapies, I think that speaks to a lot of these patients that come off.
Okay, terrific. Marie, that was outstanding. Thank you.
Thank you.
We're going to move on to the next speaker, Dr. Julia Shin, who is one of our partners in the Active Transplant group. Julia is going to speak to us about that. Before I will two quick housekeeping items before we do that from the chat and the QA. We will see your questions. One question was, will the slides be available? The answer is yes. We are at the moment live on YouTube, streaming globally, and the slides will be, the lectures will be on YouTube. Also, you can view them after.
They can see the printer.
They cannot, but they can see the mouse.
Okay, great. Okay, thank you, Uli. I am going to be talking about guideline-directed medical therapy in heart failure with preserved ejection fraction. I have no disclosures. So sorry. All right, so what is heart failure with preserved ejection fraction, or HFpEF? HFpEF is defined as signs and symptoms of heart failure due to elevated LV filling pressures despite having an EF of 50% or greater. We know that the incidence of HFpEF is rising, and now it accounts for more than half of heart failure cases in this country, with outcomes that are just as dismal as HFrEF. So, I've told you that HFpEF is heart failure, signs and symptoms with an EF of greater than 50%. So we have a 60-year-old man here who has signs and symptoms of heart failure. His EF is 60%. He has carpal tunnel. He's got a thick myocardium on echo, and he has a positive PYP scan. Does he have HFpEF? He does not. He has TTR amyloid. So what about this woman who's 65, who also has dyspnea, leg edema? EF is 60%. She has a history of radiation from breast cancer. You see on CT scan, she's got a thick pericardium, and you see a septal bounce on echo. Does she have HFpEF? She does not. She has constriction. Then finally, a 52-year-old man with signs and symptoms of heart failure. EF is 70%. He's had an MI. You hear a 2 out of 6 holosystolic murmur. And then on echo, you see a flail mitral valve leaflet. Does he have HFpEF? He does not. He has valvular disease, right? So what's really important here, in order to diagnose HFpEF, you have to rule out all the cardiac and the non-cardiac mimics of HFpEF. So there are diagnostic scoring systems that can help with this. This is the H2 HFpEF score. You get points based on which criteria you meet. So if your patient is heavy with a BMI of greater than 30, you get 2 points. If you are on more than two or more antihypertensive medications, you get 1 point. Atrial fibrillation buys you 3 points. Pulmonary hypertension, as seen on Doppler echo, gives you 1 point. If you are elder-ish, age greater than 60, you get 1 point. And then if you have evidence of elevated filling pressures based on Doppler echo, you get 1 point. You add up all the points, and if your patient has 6 or more points, this is highly diagnostic of HFpEF. The laptop is unresponsive. Oh, there we go. Okay. Yeah. Okay. So the HFA-PEF score is a little bit more granular. So you start with your pre-test assessment, look for signs and symptoms of heart failure, you assess for comorbidities, and then you do your echo. The echo then gets looked at for functional characteristics and morphologic characteristics of heart failure. So the way the scoring system goes is if you meet bolded criteria or major criteria, you get 2 points for each. If you meet minor or non-bolded criteria, you get 1 point. So functional criteria are looking at signs on echo for diastolic dysfunction. An E prime or a strain velocity that looks like diastolic dysfunction. And then the morphologic criteria focus on left atrial enlargement and evidence of left ventricular mass increase. So you get points for that. And then this scoring system also requires a natriuretic peptide to be sent. And based on whether you are in sinus rhythm or atrial fibrillation, if you meet these cutoffs, you add up all the points. And if you have 5 or more points, this is also highly diagnostic for HFpEF. If you are looking for specific etiologies, such as cardiac mimics, you should chase that with a cardiac MR, CT, PET. You can biopsy if that's indicated, or you can send off genetic testing if that's indicated. In cases of uncertainty, so if you have a patient that clearly has signs and symptoms of heart failure, but are not meeting any of these criteria for HFpEF, you should chase that with functional testing. So we do that either with exercise echo, so looking for evidence of diastolic dysfunction on echo, or you can do that with hemodynamic measurements in the cath lab. And here you see Dr. Yurdi has a patient on the table, Swan-Ganz catheter in place. He's done baseline PA catheter measurements, and then he asks him to start cycling. So after a few minutes of exercise, you repeat the PA catheter measurements, and you find in this patient where at baseline, he really had relatively normal PA pressures and wedge pressure of 14. After a few minutes of exercise, you see that the mean pressure, PA pressure has gone up to 37, the wedge pressure has gone up to 26, thus solidifying this diagnosis of HFpEF, right? So remember, you have to have evidence of elevated left ventricular filling pressures in the setting of a normal LV ejection fraction. So to summarize the diagnosis, you have a patient with signs and symptoms of heart failure, EF greater than 50%. You rule out non-cardiac mimics, so you make sure the patient does not have end-stage renal disease, liver disease, pulmonary disease, or chronic venous insufficiency. You rule out cardiac mimics, so you're looking for things like infiltrative cardiomyopathy, HOCM, pericardial disease, valvular disease, high output heart failure. And then if you've ruled out all of these mimics, then you have your diagnosis. Super important in HFpEF is to identify the relevant comorbidities, because the treatment of HFpEF really does center around treating the comorbidities. So comorbidities include hypertension, diabetes, AFib, obesity, and coronary disease. This slide kind of calls together the data to support medical therapy, the medications that are approved for HFpEF. So you have your ARBs, you have the mineralocorticoid receptor antagonists, and you have ARNI. More recently, there's been a slew of data to support the use of SGLT2 inhibitors in HFpEF. And our societies give us guidelines, right? So you have your American societies, the ACC, AHA, and the Heart Failure Society, and then you have your European Society. And you will see that the American societies give a 2B indication for ARB, for aldactone, and for ARNI. You will see that there are no recommendations for ACE inhibitors or beta blockers in the treatment of HFpEF, or calcium channel blockers for that matter. If the patient is decompensated, there's a one recommendation for the use of diuretics. You have to treat the comorbidities of hypertension and hyperlipidemia. And then SGLT2 gets a 1A endorsement from the European Society, and the American societies give it a 2A endorsement, that the ACC states to use SGLT2 as first-line therapy in HFpEF patients. you look at non-pharmacologic recommendations to screen the etiologies and morbidities is a 1A. And then just a mention about CardioMEMS. This is a pulmonary artery sensor monitoring. It's a 2B recommendation from the ACC based on the CHAMPION-HF and GUIDE-HF trials. So to summarize the society recommendations for HFpEF, SGLT2 gets first line. Currently, there's a 2A recommendation, but the prediction is that with the next iteration of the guidelines, this will be a class 1 recommendation. If your patient is fluid overloaded, you get a loop diuretic, and then you add on your aldactone, you add on the Entresto, and then if they're Entresto intolerant for whatever reason, they get an ARB. So it's SGLT2, MRA, ARNI. It's a 3-drug regimen for HFpEF. SGLT2 inhibitors are an interesting class of drugs. They inhibit the sodium glucose transporter 2 receptor in the kidney, and by doing so, you increase urine glucose and you increase sodium excretion. It's easy to say that patients feel better because they pee more, but what turns out is that these medications have multiple pleiotropic effects that I will describe in the next slide. There are adverse effects, right? So if because you have more sugar in your urine, you're prone to having more UTIs or genital infections. If you have peripheral vascular disease, there is a risk of lower limb amputation. We talked about with Marie about the volume depletion risk because it is a diuretic. And then they should not be used in type 1 diabetic patients who are on insulin because of the risk of diabetic ketoacidosis and hypoglycemia. So SGLT2 inhibitors will decrease your renin-angiotensin system, decrease sympathetic nervous system, decrease oxidative stress and inflammation. And by doing so, it really impacts multiple organ systems that improve outcomes in heart failure patients. So at a vascular level, you get improved endothelial function, decreased blood pressure. At the heart level, you decrease preload, you improve diastolic abnormalities, decrease fibrosis. There is a nephroprotective effect as well. So by decreasing albuminuria, increasing the tubulo-glomerular feedback mechanism, the kidneys improve. And then there's a general metabolic effect as well. So patients lose weight, they have increased ketones, they have decreased insulin resistance. So as a whole, SGLT2 inhibitors are are very pleiotropic in its effects. So if you think of HFpEF really as a syndrome, right, because that's what it is. So HFpEF patients have hypertension, diabetes, obesity, chronic kidney disease, and these diseases increase oxidative stress, increase fibrosis, increase hypertrophy, that all lead to diastolic dysfunction. So what do SGLT2 inhibitors treat? Well, look, they treat hypertension by decreasing blood pressure. They clearly treat diabetes. That's what the drugs were originally made for. Patients lose weight, so it treats obesity, and it treats chronic kidney disease. So by treating the syndrome of HFpEF, you decrease all of these abnormalities and end up with an improved diastolic function. And this is just the data that supports the use of SGLT2 in HFpEF. Emperor preserved looked at empagliflozin. There is a clear benefit in outcomes, and Deliver looked at dapagliflozin. Again, a clear benefit in outcomes when it came to heart failure hospitalizations and death. And the results were similar across diabetic, non-diabetic patients and across the spectrum of EF. The earlier you start these medications, the better. So if you look at this data, where patients were started on SGLT2 inhibitors in the hospital before they were discharged, see there is a clear benefit that's conferred when it comes to heart failure rehospitalization or death. So and these drugs should be on formulary at most hospitals now. So if you have a patient that gets admitted with HFpEF, start the SGLT2 before they leave the hospital. So, all right, so now it's time for an audience response question. You have here Elon Musk, Oprah Winfrey, Boy George, Kelly Clarkson, and the question here is, what do they have in common? Are they next season's contestants on Dancing with the Stars? Have they pledged $1 billion to Montefiore for free medical care to the Bronx? Or have they all copped to the use of Ozempic to lose weight?
Let's start it over. Let's just.
Yeah, great. Okay, so it is true. And why am I talking about Boy George? Because Ozempic may be the new kid on the block when it comes to treatment of HFpEF. So Ozempic is semaglutide. It is a GLP-1 agonist. And this study was published in the New England Journal last year, looking at semaglutide in patients with HFpEF and obesity. Obesity is a very common comorbidity. In fact, about 80% of HFpEF patients are obese. And they found that patients who were randomized to semaglutide had an improvement in their KCCQ score and a decrease in body weight. So, it's easy to say, well, they lost weight, of course. That's why they're feeling better. But, I think these medications are much more complex than that. And we are likely to find out that they have, like the SGLT2 inhibitor, probably have multiple pleiotropic effects on multiple organ systems that ultimately confer a better outcome in heart failure patients. Dr. Yancy will be talking about this class of medications in his talk, and I'm excited to hear more about them. So just a brief comment about CardioMEMS. CardioMEMS is a pulmonary artery sensor that gets implanted in a branch of the pulmonary artery. And by that, we can remotely monitor the patient's PA pressures. So you see on the bottom left here, the fidelity of the PA tracing that we can see on the monitor. The data we get is heart rate, PA systolic, mean diastolic pressure, and then this gray graph here looks at PA mean over time. So this patient she's I think in her 60s, has HFpEF, has very symptomatic, was hospitalized a few times before I implanted her. So she got implanted in July of 2023. And you can see that with our interventions, her mean PA pressures dropped down nicely. There's a little bump here. We upped her diuretics, and then she stayed down with improvement in symptoms and has not been rehospitalized since. So if you have a patient who is symptomatic with heart failure, regardless of the EF, has had a hospitalization or has elevated natriuretic peptide levels, then they will meet criteria for CardioMEMS implantation. So in conclusion, management of HFpEF really centers around managing the comorbidities. SGLT2 inhibitors are first line and really should be initiated in the hospital before they get discharged. On top of that, you add your MRA or ARNI or an ARB if the ARNI is not available. GLP-1 agonists should be added in those patients who are obese. And then one should consider CardioMEMS implantation for symptomatic heart failure patients.
Great. Thanks. Are there questions from the audience? Maybe Marie.
Yeah, I actually have a question.
Yeah, you said this mic.
Could you just comment on your approach to patients that do develop genital infections or UTIs on SGLT2 inhibitor?
Yeah, I mean, so UTIs and yeast infections are I think they're a little bit different, right? So women who develop yeast infections, that's easily treated with antifungals.
Sorry,
Yep.
just repeat the question.
Oh, yeah, sure. Okay, so Marie was asking, you put a patient on an SGLT2 inhibitor, they develop a urinary tract infection, or women can develop yeast infections. What am I doing with the SGLT2? I will give them one chance, right? So I treat the UTI or the yeast infection, and then after treatment, I will restart the SGLT2. If they develop another one, then I tend to just stop it. But, I think practices differ. What are you doing with it?
Well, I've been doing the same. Honestly, often more than not, the patient tends to be the limit. I mean, the patient will just say, I'm not taking this anymore after a couple of times. But I asked because there's doesn't seem to be guidelines out there in regards to this. You know, should you stop the SGLT2 during that treatment period and then re-challenge them? Should you treat through it? Do you give it 2 chances, 3 chances? There just doesn't seem to be guideline out there on how to approach this. Although, as I said, in the end, I find that usually the patient's the limiting factor. I have had one patient that has developed foreign skin brain, so it can happen. But in general, they tolerate it very well. But you know.
Right. I mean, I do think it's exceedingly rare. Urinary tract infection in the literature, I think, is 1%. Exceeding is a
I
relative
think
term.
clinically, I mean, I don't know. It feels like it's about 10% or so in practice.
All right. But any of the other heart failure physicians have you seen it quite a bit also doing?
Not really.
Not really either. I've actually never seen it. But there's somebody in the let's go.
I've seen it. I agree more with Marie's percentage, because, especially in diabetic patients. I think it's you know, it can be a problem. I also have a question for you regarding the use of SGLT inhibitors in patients who have a urinary catheter. Do you use it? Because in that situation, the risk of urinary tract infection is highly increased.
Yeah, I can tell you what I have done. I actually do have one patient who has to straight cath himself because of urinary retention. And he has had, you know, at least 3 urinary tract infections, and I've elected not to start the SGLT2. But again, like Marie said, there are really no guidelines to any of this. So I think we're kind of, you know, flying the plane as we're building it, so to speak.
Yeah, that's also my approach. Maybe that's why I don't see it much. I saw a patient yesterday at White Plains, you know, a 79-year-old woman, and she has recurrent UTIs and HFpEF, and I decided not to start the SGLT2. In the literature, again, it's only 1%. Sometimes that's underreported, but in a randomized clinical trial, I think that's kind of the hard data. Then the actual patients may be at higher risk for UTI. Great. Okay, that was outstanding. One of your questions in the back, just yeah, right.
This might not be realistic, but like, would a concurrent diet modification in these cases help to mitigate this? And also have, just put that there.
Would concurrent diet modification mitigate?
Eliminating, but drastically reducing the amount of carbohydrates they take.
Mitigate HFpEF, you mean?
Yeah.
Yeah.
And also,
yeah, I mean, that would treat the comorbidities of obesity, diabetes, right? So, yeah, I would say likely.
Well, I was mainly thinking in terms of the UTI with the higher.
Oh, the UTI.
Yeah, the question was, I'm just repeating it for the 82 people on Zoom, whether diet modification, glucose, I guess, at the time of SGLT2 inhibitor initiation would modify the risk of UTI, and I think the answer is we don't know. Great, I think we have to move on. Yeah. Great talk, Julia, thank you. And then Catherine Paolo, who by original training is a PharmD, but has completed additional training, is also now an MBA, Master of Science, and Assistant Professor of Medicine, and directs our Transitional Care Excellence Program, which over the past 5 to 10 years has really shown exceptional results under her leadership. So Catherine, this is the real world at MonteHeart now, away from randomized clinical trials. Here's what really happens. So thanks, Catherine, for making time.
And thank you, Dr. Yordi, for inviting me. So I am very excited to talk about our journey, No Patient Left Behind. So these are my disclosures. They're related to real-world implementation science for guideline-directed medical therapy. We'll start with defining transitions of care, because I think we know what a transition of care is. And right, that's the movement of patients from one setting to another, from hospital to home, from CCU to a telemetry unit, from general cardiology to heart failure specialty. But when we talk about transitional care, it's a little bit more nebulous. And this definition is from the 1980s, but this is the core of transitional care excellence. And it is a range of time-limited services, typically around 30 days post-discharge. And it's meant to complement primary care. Well, what is primary care? Of course, it could be primary care providers in the typical sense, or it could be, as we approach it, an extension of hospital-based care, of heart failure specific care, or general cardiology. We see ourselves as partners and extensions of these services. And the interventions that we're delivering are really designed to ensure continuity and avoid preventable poor outcomes, such as readmissions. And then, of course, among at-risk populations, well, that is our cohort in the Bronx. We serve some of the most medically complex and socially diverse patients in the country. So that is our definition of transitional care. And when we think about what can go wrong in transitional care, the answer really is everything. So this is for those quality improvement enthusiasts and specialists. This is an Ishikawa diagram, and it's used to really identify causes of a problem so you can start to systematically address them. And this Ishikawa diagram comes from Dr. Yancy Albert from the Cleveland Clinic, who is a master of transitional care. And you see that there's so many things that can go wrong within that 30-day window. But at its core, transitional care is challenging because these problems are not unique to Montefiore. They're not unique to the Bronx. They are really representative of some of the systematic issues that are challenging in our national healthcare system. Cost of medications, cost of care, access to providers, access to specialists, access to medications, disparities in care, as well as fragmentation and silos. Sometimes we see patients with just poly providers, and they have 5+ providers that are caring for them, but not doing it as a team approach with no coordination. So as we've approached, quote unquote, fixing transitional care at Montefiore, we're really tackling some of these much bigger issues. And what are the consequences of ineffective or poor transitional care? Well, the first, is related to our outcomes. This can result in a delayed diagnosis, workup for amyloid as an outpatient. Well, if we don't schedule or plug that patient in, months could go by. Delayed treatment, medication errors. Patient experience is huge. A lot of times when we're working in silos, patients will even say to us, do you not talk to each other? I just got asked that question, or this person just called me. So there's a lot of frustration. It can impact your patient experience scores as well. Of course, cost. Ineffective transitional care can lead to patients using the hospital as their primary source of care. They're not getting plugged into ambulatory services. So hospital is number one, and hospital care is most costly. And from the care team, the provider clinician experience, it's inefficient, it's ineffective, it's duplicative, it's frustrating. It's frustrating when you had a plan for your patient and then at the next step, it didn't get followed. This is based on the quadruple aim, but we're now up to a quintuple aim. So the last, kind of consequence of this really relates to health equity. So poor transitional care, of course, can result in disparities in care, which is something that Montefiore is not okay. So to really measure, transitional care quality, there's different utilization metrics in value-based care. We all know the hospital readmissions reduction program. This has been around since 2012. The Affordable Care Act basically said that if you have excess readmissions within a 30-day period after a hospitalization for heart failure, as well as other conditions, we're going to financially penalize you, the hospital. But there's other metrics that are also in play here. Star ratings, which is the publicly reported, perception of the hospital available to consumers to help them make decisions as to where they receive their care, 1 to 5 stars, with 5 being the best. Well, the star ratings includes your readmission rate, as well as another metric that's called excessive days in acute care, which is a more holistic picture. Not just did you get readmitted, how many times did you use the ED or observation? And if you did get readmitted, what was your length of stay? AHRQ also has prevention quality indicators. That's more on the managed Medicare side. And they're looking at the the admission rates for patients with heart failure, because they consider that to be a ambulatory sensitive condition, and they don't want their patients to get admitted the first time. So what we see here is that no matter what your payer is, Medicare, Medicaid, commercial, transitional care is very important when it comes to quality. And CMS, the federal government, has told us it's only going to be increasing. By 2030, all Medicare beneficiaries, as well as the majority of Medicaid, are going to be in some type of value-based care relationship. So this is definitely something that we need to keep our eye on and be proactive about this. So I'm going to be speaking in front of Dr. Yancy, and I cannot ignore the guidelines and what they say in terms of transitional care. So these are the recommendations. There's kind of 4 themes here. The first we've already touched on today with Marie's talk, and that's the team approach. A multidisciplinary heart failure team is recommended to reduce the risk of hospitalizations. When it comes to discharge, the patient really needs to understand their journey. This is one that is really challenging and we're working on, but a patient-centered discharge instruction with a clear plan, which shouldn't be follow up with your providers and call for an appointment eventually. So the other one is really related to the system. We say the system gets what it puts in. And if you can't measure it, you can't improve it. So benchmarking performance is really a good strategy to increase the use of guideline-directed medical therapies and improve quality. And finally, this one is so important, that early follow-up, getting patients back to their providers within 7 days of discharge. And this is something that in practice is very challenging to have that 7-day access. But this is what we're striving to do. And going back to how we've designed our transitional care program, which we started back in 2016, we created a multidisciplinary, bundled and integrated approach with evidence-based interventions. And this included early admission assessment, ensuring that patients had standardized education, coordinating telephonic follow-up within 2 days of discharge, referring patients to home care visits with nurses, including caregivers, working on communication, handoff, and of course, aiming to get appointments prior to discharge and having a very early follow-up. Switching gears to, from what's recommended on the national level to the local level at MonteHeart Medical Center to just talk about, how challenging this is in practice. Well, here in the Bronx, we have over 3,000 admissions for acute decompensated heart failure per year. And this is across 3 hospitals in the Bronx. It's across different service lines. So other strategies at perhaps smaller community hospitals is you cohort your patients. Can't do that here when you've got 3,000 patients, a couple of the busiest emergency departments in the country, and you need beds. So we have, created our heart failure program on every single unit here in the hospital. And that also gets into our, goal of not having disparate care, where if you're on a tele unit, you get a heart failure program. If you're on, med surgeon with a hospitalist, you don't. Our heart failure program and our bundle is everywhere. And in 2016, our 30-day readmission rate was identified as a strategic priority and a system effort as it related to quality. We started out with one of the worst readmission rates in the country. Our Medicare fee-for-service rate in 2016 was 24.3. And when it came to other payers, it wasn't quite good. It was 22%. And we were returning about $750,000 each year back to the federal government in penalties. So our approach to this was really to come up with a mission. And it's not to reduce the readmission rate. Our mission was to deliver evidence-based inpatient and transitional care interventions that I've described. Why? To decrease morbidity and mortality. And the vision here was also to have this be a system effort that wasn't just hospital-based, but collaborative across our faculty practice group, across our primary care medical group, through our managed care, home care, so that we could start to get on the preventative side and be more proactive and keeping our patients out of the hospital to begin with. From that, we later built our transitional care excellence program. So I'll share some of the results which led to the funding for transitional care excellence. But we started to think beyond the guidelines and look to see what we needed specifically for our patient population to do more. That used to be our motto at Montefiore, doing more. We're now Montefiore Einstein, but we were trying to do more, and we created a multidisciplinary team of clinical pharmacists, nurse practitioners, and associates that support them to really drive and support the continuity. We had implemented our original bundle with no staff. And we just worked on the, I think, overarching desire of the clinical teams wanting to improve care, but you get to a point where you can't keep adding things without having additional resources. So our additional resources really took ownership and drive, the delivery of these patient-centered interventions throughout the hospitalization and the 30-day discharge period. And of course, while the mission is still hospital to home, safely transitioning, we're getting into a vision that is really looking at hospital medicine and the hospitalization as an opportunity to improve, chronic disease management. Our patients don't just have heart failure, they have diabetes, they have CKD. The cardiovascular kidney metabolic syndrome here in the Bronx is so prevalent, so that if we, are just looking at, 4 pillars and not addressing the fact that the patient has a uncontrolled, A1C and doesn't know how to take their insulin or can't afford it, that's not a good service for our patients. So we're really trying to encompass a holistic chronic disease management during the time of hospitalization. So moving from that single reason for admission to this holistic, and having that same clinician who sees you in the hospital follow you through that 30-day window. Our motto on Transitional Care Excellence is call us first. We're there to help navigate both the system at Montefiore, whether it's you can't access your medications, you forgot your discharge paperwork, and you don't know when you should see Dr. Yordi in clinic. We're there to help that navigation, and we're also there for the clinical navigation between providers and providing recommendations. Our focus areas in intervention, so as Dr. Yordi mentioned, this is my bias. I am a pharmacist, so pharmacoequity is incredibly important. In 2024, I will say there's never been a better time to be on guideline-directed medical therapy. We have so many drugs in the CKM space that can improve outcomes, but we need to get access to them. So if we recommend a SGLT inhibitor, we're also going to do the prior authorization or tell you which one is covered by the insurance so that the work doesn't have to be done by the kind of receiving team. We screen for social determinants of health. I'm very proud to say that our team started screening for social determinants before it was a Joint Commission requirement. We set up transportation to appointments. We plug patients into community-based resources or health systems resources as they exist. And we do this prior to discharge so that patients don't leave the hospital with a to-do list that is just overwhelming. And really getting into, patient-centered follow-up. A lot of times we said, next available appointment, I'll take it. If it's on the same day as dialysis, it's probably not going to work. So we're really trying to take into account patient preferences. The Bronx is sprawling. If they can't get there on public transportation, chances are they're not going to show up. So when we ask, your patients, and we're scheduling their appointment, we're taking all of this into account so they can get to their forever providers. So with that in mind, how did we do? These are our internal results. Again, we started off one of the worst in the country, 24.3 in a Medicare fee-for-service. And in 2023, that rate came down to a number that is almost so scary to sustain 13.2%. And you see that reduction over time. Again, hospital readmissions reduction program, the financial piece of this, well, again, started off with a penalty just for heart failure alone of $743,000. In fiscal year 24, no penalty. And CMS data lags. So Dr. Yordi started here in 2014. I started here in 2015. On our watch, this has gotten nothing but better. And I think one of the most remarkable things here is that the balancing measure is mortality. And our mortality has also improved in this time period. So we have not done this at the expense of increasing mortality, which is something that you have seen at other systems. So over, 2.7 million saved. I also hot off the press for fiscal year 25, no penalty. And in that other measure that is more challenging to address, the one that incorporates length of stay, we've improved our performance to almost a 3-star level. But again, at MonteHeart and the mission of excellence, which is not in just transitional care, but in cardiology, we're not 3 stars, we're 5 stars. So being, no worse than national average is not our goal. It's to be better, and we will continue to do so. So what are the keys to success? Well, it's, the formation of a strong and guiding mission and vision, which is, again, evidence-based care. Collaboration and relationship building, working very closely with Dr. Yordi, Dr. Garcia to continue with this mission for excellence. Again, having the data, providing the data system, gets out what it puts in, and having a leadership and culture. This was a, top-down initiative from one of our senior vice presidents, Dr. Weiss, and continuous quality improvement. I can say now, again, in 2024, there has never been more excitement among trainees to do QI. In fact, we will be launching a project very soon to improve prescribing of guideline-directed medical therapy in patients. And the project's called WWJD. What would Dr. Yordi do to improve medical therapy at the time of discharge? So thank you so much. It's been a pleasure.
Yeah, Catherine, that was really outstanding. And really credit goes to her, I have to say. I love working with you. Yeah. But it's true, it's about the relationship that has been built. We struggled for the longest time to get patients into the heart failure clinic. And the emergency room wants to send them, everybody wants to send them. And I have to say, I did not allow scheduling into our clinic without a physician being somehow involved in giving us the story of the patient, and to avoid that the patient gets sent to us from the ER with no prescriptions, with 5 other medical problems, and then the heart failure clinic is clogged. Working with Catherine, her entire team is allowed to schedule into our schedule without consulting us. So I think that has been a big change, and thanks to your team. But let's open it up to questions from the audience.
So Catherine, you mentioned very well that part of the success is analytics. So I have a question for you. Have you noticed any relationship between length of stay and readmission rate? Can we say that we can reduce readmission by keeping the patient longer in the hospital on their additional admission?
Yes, and it's an unpopular opinion because we are so length of stay focused, but we have been looking to think about this more like a 30-day episode, if you have 2 readmissions for heart failure within 30 days, well, why not keep you longer the first time? We know this because we don't want 2 admissions within 30 days because of what it can do for outcomes. But now I would say from the hospital perspective, they're like, yeah, maybe an extra day or 2 or 3 to get the patient back to dry weight is going to be a good thing. We just did, in preparing for AHA, we just did a review of all of our 23 readmissions, and it was done by a multidisciplinary group, including hospital medicine and cardiology fellows and house staff. And they said, yeah, there's a huge opportunity like to diurese to dry weight and get into that, standardized approach and diuretic protocols. So,
Catherine, congratulations with your presentation as usual. Going on this question that Dr. Garcia placed, in addition to, there are standard, diuretic is standard all over the place. Do you think that the geographic population that we have and the diverse population that this area has may play a role? Because, the field of medicine is pushed in, get out of the hospital as soon as possible. But it may be okay in some area, and it may not be good here just because of not the standard protocol, but just patients are more alone, are less going. So should we, really focus on the way the state or the government judge us should be different than what is in other places?
Yes, absolutely. And I think we need to invest on the hospital side more into social determinants of health, because when patients screen positive and they don't have insurance, it's not safe to discharge. We know what's going to happen. They're going to be right back. We're saying, here's 14 days of charity meds and an appointment in 3 months. Like, that's not going to work. So in addition, it's great that we're now screening for these, but we need to start thinking more proactively. My team is addressing some of these from the get-go, but some of these do require, longitudinal follow-up, especially when it comes to, housing at risk. That's another challenge. It also, I think by addressing these sooner, they don't get to, your teams for consideration of advanced therapies, like there's no social support, unstable housing, and what can we do for this patient? So I completely agree. We need to, in the Bronx, start, putting these social needs as part of the inpatient, treatment plan. Yes.
Has there been any measured difference between patients who go home with home care nursing as opposed to patients who don't, in terms of readmission rates?
Yes, the question was, has there been a difference in readmission rates between those who go home with home care nursing versus no? Yes. And as we would expect, patients who are getting visits from a registered nurse in the home have a lower readmission rate. One of the unique things that we've done with our home care program is added both social services and have social work evaluations, as well as PT. And that's because, getting all of the patients who need and would qualify for cardiac rehab is challenging due to access. So after the RN has their initial visit, they will then refer out to a social worker to address some of those social needs in the community, or for home PT, so we can have, a home rehab program. So.
Outstanding job. My question was, can you please explain a little bit more in detail what your team is made of? And, in my hospital, constantly struggling with receiving intervention, but are not with that person. So how do you take your model and implement it throughout the hospital? Can you explain your team's role, inpatient, outpatient, and what is the goal? That would be really helpful to you.
So the question was, what is the composition of the transitional care excellence team, and what is their role kind of through that inpatient and outpatient? So the transitional care excellence team has, I'll use this campus as an example, 5 team members. There's 2 nurse practitioners, 2 pharmacists, and a support associate. We're a consult service, and we see patients for, of course, heart failure, AMI, as well as the pulmonary side of the house. That's my other job, COPD and pneumonia. So we have a designated cardiology NP, a designated cardiology pharmacist, and once we are consulted by the team, sometimes we do go shopping. We do find these patients as well. We are looking at, in our assessment, what medical therapies are they on? We're providing these specific recommendations for 4 pillars or 3 pillars for HFpEF. We're looking at some of the other chronic diseases to see if we can optimize there, if that's like going to be a high risk for readmission. We then set up the follow-up, determining where they belong. If they do not have established providers, Dr. Yordi has given us a clinical protocol that we call Leapfrog, so that somebody who has an EF of 10 goes right to the heart failure team. You know, we have patients who with an EF of 10 have never seen a cardiologist, so we plug them right in. We can make a very patient-centered appointment. From our perspective, that's one of the most important interventions. It's in the guidelines, getting them to their forever provider, setting up the transportation. We then call 2 days after discharge, do that standard assessment. Did you get your medications? How are you feeling? Your appointment reminder, review the discharge summary. And then depending on when they're going to see their forever provider, we come in one more time, either to reinforce all of the information or possible medication changes that they've had with Dr. Yordi at his visit, or as a bridge if there's no access until 21 days. And then we tell our patients, call us first. We're here for 30 days. They call us 90 days later. I think we still have a couple patients who are texting us because we're easy to get a hold of. So that's our model. Happy to talk offline and give more details. Thank you.
Great. Thanks.
But really incredible. Many of those lectures are given, but the numbers, I think, speak to your work. Enka, can you just do this for me? Thanks. So now we come to our first keynote, and probably the highlight of the meeting, Dr. Clyde Yancy, who I will keep my introduction relatively short because everybody seems to know him. He's already getting hugs. And Clyde has many titles, is really a legend in heart failure with over 750 publications cited in PubMed. I always thought I was prolific, but I'm now stand very humbled, having just looked that up. He's the chief of cardiology at Northwestern, also the vice dean there, the deputy editor of JAMA, the prior president of the American Heart Association, and many, many titles. I just want to show a picture. We talked about it last night, how relationships are important. Clyde and I spent a day in Berlin with Nia Oriel 5 years ago and toured the history of Berlin as a Jewish Israeli with Holocaust survivors, an African American and a German with the family history that most Germans have. And we walked there, and it was an incredible experience. So that's probably my most important relationship to Clyde. Everybody here knows him. I think he's famous internationally for his work in heart failure and what he has done for our patients. So with that, he will address a very exciting topic evolving right now, heart failure.
Good morning. Now, really? After that invitation build up, I said, good morning. I'm opening my heart. I'm hugging you. So let's try this again. Good morning. It's much better. This is my first time in the Bronx, so you got to show me some Bronx love, okay? Listen, in all candor, I really am so pleased to be here. And that day spent with Dr. Jordi in Berlin on a walking tour with Dr. Uriel really was one of the milestones of my life, and it gestated the idea of being a visiting professor here. And this meeting provides that opportunity. So my first thanks is to Dr. Jordan. I've known Dr. Garcia for such a long time. Dr. Goldstein is a friend. Dr. DiBiase has been my guest in Chicago and has become a friend. Maria Gallo, we've been doing this heart failure thing. You just disappeared. I don't see you. But we've been doing this whole thing.
Back in
There you
clinic.
go. Back in clinic, doing this for at least 20 years together. So I feel very familiar here, even though it's my first time. Listen, I want to help everyone change the frame. Before I start speaking and sharing my content with you, I want your rapt attention in me, not on the screen. I want your rapt attention here. I want you to think about the focus of today's meeting. Today's meeting is focused on heart failure. I intentionally want you to think about removing the concept of failure from your conceptualization of this disease process. And I intend to validate that reframe thinking, not only by the preceding information you've heard, by what I wish to share. My task is to talk about GDMT pillar therapy, heart failure, and to introduce a fifth pillar. But let me start with the model. Let's set up the mental framework by thinking about how do we even get to a point of guideline-directed medical therapy. This is critically important. I just left a meeting in downtown New York, challenging ourselves to iterate the way we evolve an evidence base. Many years ago, our evidence base was predicated primarily on observation, on empiricism. It makes sense, so let's do it. That yielded to observational science, which was the rigorous collection of longitudinal cohort studies, so we could learn from things like Framingham, what puts people at risk. And then it yielded 3 incredible decades of randomized controlled trials. And this graphic shows you the surfeit of randomized controlled trials conducted specifically in the area that legitimately was heart failure. But out of these trials emerged some striking observations sufficient to really inform the way we proceed forward with clinical practice. What does that mean? It means we have this. This is so incredibly important because this is no longer an algorithm of care. This is an algorithm of success. We have to establish the diagnosis. That's not a necessary conversation today, but you see 4 green boxes. I've been an author of the guidelines, these guidelines, since 2003, and I was chair for a decade between 2003 and 2022. This is color-coded deliberately. The green light means this is a class of recommendation 1. And that means you should think about it. It means you should do this. And there are 4 class of recommendation 1 suggestions. 1 is RAS inhibition, evidence-based beta blocker, mineralocorticoid antagonist, and sodium glucose cotransporter 2 inhibitors. That's guideline-directed management and therapy. The medical aspect of this is these 4 therapies. And then there's a stepwise approach that has become really the most important foundational element in the appropriate care of patients with reduced ejection fraction heart failure. It gets us all the way to some of the concepts that you'll discuss tomorrow, specifically about advanced disease. But my conversation with you is not about treating advanced disease, but endorsing this upfront first consideration with the pillar therapy. These are the 4 pillars, as we like to suggest, and it really does identify a way that we can improve outcomes. But let me engage you in something else. Let's do a thought experiment. For several years now, particularly since the release of the 2022 guidelines, we've talked about quadruple therapy. We've talked about the 4 pillars. And if you look very carefully at the graphic that I just shared with you, each pillar has the same robustness and size and the same height. Perhaps it's time for us to think about a version 2.0. Now, what might a version 2.0 entail? First, it might mean that we can take the frame beyond HFrEF. Dr. Shin talked to you about HFpEF, but there's also heart failure with mid-range ejection fraction. But perhaps we can think about this multi-layered therapy in more phenotypes of heart failure. Secondly, think about this. I would argue that if I followed one of you to clinic today, the way in which you're treating patients with heart failure using guideline-directed medical therapy is based on an historical sequence. You start the RAS inhibition first, and then you add the beta blocker, and then you add the MRA. You see how the patient does, and then you add the sodium glucose cotransporter 2 inhibitor. Might there not be a better approach if we think about the impact and the timing? And then we talk about 4 pillars as if it's a fait complete. That's Latin for a done deal. But is that correct? Is there a 5th pillar or maybe more pillars? So let's explore this in a little more detail. First, let's think about the indication for these guideline-directed medical therapies in phenotypes other than HFrEF. It's a brilliant analysis done by Carolyn Lamb and colleagues that looked at each of the classes of indicated therapies: RAS inhibitors, the RNA compound, beta blockers, MRA, and the SGLT2 inhibitors. Look at the graphic. Look at this graphic. Only 1 point estimate, only one, favors the alternative, favors a control. Every other point estimate, regardless of ejection fraction, favors the elements of 4-pillared therapy. If you look at the 2 extant guidelines, the ACC, AHA, HSFA guideline, and the ESC guideline, you see the class 1 recommendations, but then go from reduced DF to mid-range to HFpEF, and you see particularly the US guidelines provides latitude to use these therapies as evidence-based suggested regimens. And so we can make the argument that we can expand the frame of 4-pillar therapy beyond HFrEF. I want you to pay careful attention to John McMurray's thought experiment here. This really does challenge us to think about sequence and effect. Now, I've given you the prototypical sequence. You can see if you start with the darker color, bluish purple, that's RAS inhibition, the way we've all been taught. Follow that with the gold color, that is the beta blocker. Follow that with the green color, that's the MRA. So let's be very clear because it's helpful to think this through. The upper panel looks at both heart failure hospitalizations and cardiovascular death. The lower panel looks at all-cause death, the hardest outcome to modify. The first row, sequence 1, is the traditional row, and the small numbers enumerated within each color scheme reflects the number of weeks spent on evidence-based therapy. So you can very easily see that for the one that is sequence 1, that's over 6 months before the patient is fully initiated on evidence-based therapy. Compared to no therapy, clearly there is a benefit going from 280 events to 129 events. But look at what happens if you shorten sequence, and particularly if you look at the magnitude of benefit for each drug class with the more rapid up titration. So train your eye to sequence 2 in the upper panel and sequence 3 in the lower panel. Meaning if you start with the SGLT2 inhibitor and then add the MRA, then add the RNA compound, followed by the beta blocker, a very different sequence. Compared to no treatment, 280 events to 81 events, and even compared to the conventional sequence, 129 to 81, theoretically, there is a version 2.0 of guideline-directed medical therapy that involves accelerating the introduction and changing the order, going with the agents that are most effective initially. This is not just theoretical. In our journal, JAMA Cardiology, we've published twice that the time from initiation to benefit for SGLT2 inhibitors in the setting of HFrEF is 28 days. 28 days. The time for benefit for HFpEF is 14 days. 14 days. You just heard the challenge of getting people into the outpatient environment within the first 30 days after readmission. within that first 30-day window, the patients will have already reaped a clinical benefit, regardless of phenotype, from being on the SGLT2 inhibitor. Why not think about that as a priority therapy? It's a very provocative thought process, and the same logic bleeds over if we're thinking about all-cause death. But now let's think about the really provocative point. The really provocative point is whether or not there's another pillar. If I have established for you that there's an evidence base that gives us the wherewithal to say that we can think about successful therapy, we've got 4 drug strategies. And if I've made you recognize that those 4 drug strategies extend beyond HFrEF, and then argued with you that perhaps we can revisit the timing and the sequence, how about this notion of a 5th pillar? Now, this seems a little bit incredulous, and I want to step away from the podium for a minute.
Just turn it on.
Testing.
Hello? No, that's not working. I guess you mess. Let's do the lapel.
Want to get a little bit closer to this conversation. This is really the moment where I really want you to think about it. Now, this is it's still encouraging the parking force. And it is global, it is very known up front, but there's something embedded in this incredibly important. Traditionally, when we think about heart failure, we think about what they call us insurance, smaller ones, not beta blockers, are helping the force move more efficiently through ACE inhibitors and heart transplants, and the horse is dragging through. Imagine if you allow yourself to shift your point and think about the part first. Now, I can't thank Dr. Palmer enough because she introduced CKN. This is a real cardiac kidney metabolic, driven in part, or maybe principally, by excess weight. Now, let us think about what happens when you just you had breakfast this morning. Your body releases a series of hormones called IN, CRT, CRT. And incretins are intended to establish glucose homeostasis in the body. This is present in the species to control your glucose levels. What are the incretin hormones? There are 2. Like the glucagon.
I think that one's better. I'm sorry, just stay close to it.
Yeah. Okay.
And there are 98 people on Zoom.
So the incretin hormones are twofold. The glucagon-like 1 peptide receptor, and the second one is GIP, the glucose-dependent insulinogenic polypeptide. They are intended to regulate glucose. They are the hormones in the body that lead to the release of insulin. GIP is in the small intestine and stimulates the pancreas to release insulin. The glucagon-like 1 peptide receptors stimulate the beta cells to release insulin. Now, I also want you to stay with me in this thought experiment, this cart before the horse experiment. Think about insulin. Insulin does, in fact, lower blood sugar. Anybody knows that. But beyond that, there is some deleterious effects of an insulin replete environment. It is somatotrophic, meaning it causes a growth stimulus. That growth stimulus is experienced by the kidney with glomerular hypertrophy and by the heart with left ventricular hypertrophy. Insulin is atherogenic. It promotes the deposition of lipid particles in the vascular endothelium. Insulin also stimulates our neurohormones, an increase in norepinephrine, an increase in angiotensin. So when you think about this, retarding the effect of insulin would seemingly be beneficial after we control blood sugar. And that's precisely what glucagon does. So glucagon actually is the antithesis to insulin. So this cart before the horse becomes less silly now, because if we change our frame and stop thinking about whipping the heart or slowing the heart or unloading the heart and start thinking about what's really critical here, the energy source, we open up a brand new direction. Arguably, this is one of the reasons why SGLT2 inhibitors work, because we're changing the energy source. But now what's happening in this space when we focus on GLP-1? Well, first, there are many compounds in this space. If you pay attention to the popular media, you would think that semaglutide, and you know its proprietary names, I refrain from using those, but you would think that's the only one, but that's not correct. For a number of years, literally since 2005, we've been exploring the utility of these agents in the treatment of dysglycemic syndromes, diabetes. The first one evaluated in cardiovascular disease was liraglutide, which was not effective in heart failure, but was effective in cardiovascular situations with ischemia. Understand that the reason that we happened upon this drug class was out of a safety concern, because the antecedent, the prior glucose-lowering agents, were all associated with cardiovascular harm. That's part of the buildup to the SGLT2 inhibitors. It parallels as well for the GLP-1 receptor agonist. Train your eye to the bottom of this graphic, which is where you see the more recent introduction of both the subcutaneous injection of semaglutide and the oral formulation of semaglutide. Now, I want to share with you the evidence base, because we should be driven by evidence. Ostensibly, these drugs are intended to lower hemoglobin A1C. The most important thing to do is train your eye to the far right of this graphic. Look at the purple bar, the most effective GLP-1 receptor agonist as a within-class comparison. So best versus best, the most effective one at reducing hemoglobin A1C is semaglutide, including the oral version, which has great applicability if we think about the future. If we now think about weight loss, again, the most effective weight loss agent exceeding 10% of body mass is in fact semaglutide. And so we have this concept now of a focus putting the appropriate sequence, cart and horse, on this CKM milieu, the cardiometabolic space. Try to give you a premise for why focusing on glucagon is actually quite reasonable, but it's a different way of thinking about cardiovascular homeostasis. And I've tried to share with you that these are not new. They've been around for nearly 20 years, but the newness is this understanding the benefit on cardiovascular disease. We like to think about the SELECT trial from November 2023 as our first introduction to the benefit. That's not correct. The first introduction benefit was actually in the heart failure space about a year ago in the STEP-HFpEF trial. This is in patients without or with diabetes, agnostically, but with obesity, who received semaglutide. The results were astonishing. If you look at the KCCQ indicator, let me help you with something. The Kansas City Quality of Life Indicator, if it is a delta of 3 points, that's clinically important. In this analysis, the delta was 12 points. That's a striking improvement in quality of life. Truly, it answers the question that patients raise all the time. I just want to feel better. A 12-point improvement in KCCQ, you feel better. But then the change in body weight, that occurred concomitantly, over a 10% reduction. We can talk later about whether those things are connected, because I want to get to this point. Coincident with ACC 24 was the release of the STEP-HFpEF-DM, the same study done in patients with diabetes, and then this paper published in The Lancet shortly after ACC 24, which is a pool analysis of STEP-HFpEF and STEP-HFpEF-DM. And why is this so important? First, it revalidates this important and demonstrable, meaningful change in quality of life. And it further extends the benefit on weight loss. That's expected. But this was the part that provoked us. The upper panel is looking at cardiovascular events. When you look at patients with events on semaglutide, obese patients with and without diabetes now, versus those not. 8 events versus 30 events. That is phenomenal. For those of us who do clinical trials, this is where you stop. This is where the question of ethics comes into play. So if you continue this thought experiment, then you go to the SELECT trial. This trial really bears additional commentary. Done in 17,000 patients, 42 countries. Body mass index for entry was 27.5 or greater. Let me give you a visual of what that means. My body mass index is 25.5. So someone just a little bit larger than me qualified to be in this trial. So get the obesity thing out of your mindset. 27.5 was entry. Followed longitudinally, these patients, all of whom already had cardiovascular disease, hypertension, previous myocardial infarction, previous stroke, vascular disease, and heart failure, 40% had heart failure. Every one of the 17,000 already had cardiovascular disease, and they were already on appropriate evidence-based therapies, beta blockers, RAS inhibitors, and statins. And on top of that, another 20% relative risk reduction in outcomes. Absolutely astonishing. When you look at the purple arrow that's pointing at heart failure, it's showing us that even though we don't have the statistical analysis, what we do have is a point estimate and a hazard ratio that suggests that independent 18% reduction in events that had it met the statistical analysis plan would have achieved statistical significance. So now we really do have to become less silly about carts and horses and understand how could this possibly work. A very important paper in Nature Reviews helps us understand this, and this is just from last summer. We look at the distribution of these glucagon-like 1 peptide receptors in body. We see that in humans, they're in the atria, in endothelial cells, and in ventricular cells, and in the periphery, they're disseminated throughout vascular smooth muscle. So even though we think about glucagon as being part of this glucose homeostatic model, these receptors are ubiquitously located in the cardiovascular system, more in the vasculature than in the heart, but they're in the heart as well. What do these receptors control? In the blood vessels, they control vasoreactivity and lead to a reduction in blood pressure. For the pancreas, they support endogenous insulin secretion. They lower glucose. In the GI tract, they lead to early satiety, delayed gastric emptying. This concerns anesthesiologists because the effect can last days to weeks, and that's why there's a dynamic now holding the drugs before major surgery. But they also cause side effects, and we should know these are not perfect drugs: nausea, diarrhea, vomiting, gallbladder inflammations. These are the things that are of some concern. And within the brain, not only do they decrease appetite, but they decrease other pleasure-seeking behaviors. A really wide open opportunity to think about these drugs to do things that we never imagined we could medically treat. So before SELECT, before STEP-HFpEF, before STEP-HFpEF-DM, we looked at all of the outcome trials for glucose lowering. The major adverse cardiovascular events data was stunning. This is a summary graphic showing a decrement in non-fatal MI, a decrement in cardiovascular death, a decrement in stroke. This is the part that really captures my attention. What's going on here? It turns out that if you infuse a reconstituted aliquot of these receptors, it increases the left ventricular ejection fraction and decreases the remodeling we see after injury in animals with heart failure. Next, if you evaluate what happens in animals, these drugs protect against ischemia in the setting of an experimental myocardial infarction and increase post-MI survival. Next, if you look at the animals with obesity-induced cardiomyopathy, these agents reduce cardiac fibrosis and reduce the expression of the natriuretic peptides. Moreover, they reduce TNF-alpha and reduce inflammation. And these same agents increase AMP kinase, which we know modulates myocyte function. And we know these compounds in animals decrease apoptosis. If you had to design a contemporary agent to treat heart failure as we know it today, what would you want it to do? Reduce inflammation, reduce fibrosis, reduce apoptosis, upregulate AMP kinase, protect against ischemia, increase the EF, and retard remodeling. And it improves glucose uptake. All of this has been shown in animals, but to the extent that this can be replicated in humans, it makes this not just a random observation, but it allows us to think that there's something about this biology which fundamentally changes where we are. So what's the theoretical benefit in heart failure? Starting from your right to left for HFpEF and then moving to HFrEF, a decrease in atrial enlargement, a decrease in epicardial fat, which we know is metabolically active, a decrease in adverse remodeling, a decrease in cardiac inflammation, an increase in AMP kinase, an improvement in endocardial cell GLP-1 receptor activity. All of these things uniquely beneficial and never before modulated by anything in the standard 4-pillar regimen. And then this, from just 2 months ago, this is the first meta-analysis looking strictly at cardiovascular outcomes, whether it's 6-minute walk time, natriuretic peptide levels, cardiovascular outcomes, including mortality. Everything favors the addition of GLP-1 receptor agonists on top of already evidence-based therapy. Arguably, a 5th pillar potentially is upon us. But if that's the case, I take you to this statement from Adolphus Huxley. There are things known and there are things unknown. And in between are the doors of perception. So just like I shared with you in the beginning, 3 decades of clinical trials, we can't immediately go to this 5th pillar. We can't just presume that it works. We have to persist with this generation of the evidence and establish that this really is a 5th pillar. If we can do that, again, as I started, we can change the frame and take failure out of the equation and really start thinking about success. This is my hometown, and this is my hometown in recent days and weeks when all the bridges are elevated. It may not be New York City, but it's a pretty cool place. Thanks much.
First, apology about the audiovisual. It is true that we're the last group to use this system. This will literally be all removed next week, and we get a full overhaul.
You mean
So you're last one to experience it.
last group ever?
This will be torn down, seriously, next
Okay.
week. We have questions. Also, there are 105 people on Zoom right now. If you put your questions in the chat or in the QA, we will pick them up.
That was a phenomenal presentation, and I have to say, I haven't seen you for a few years. It looks like you have found another molecule that keeps you young. You haven't changed. But obviously, you started your presentation with the important role of insulin and glucagon. And I wonder if we can also regulate the production of this hormone by dietary intervention.
So, Mario, thank you for your kind words first. And again, thanks for the opportunity to finally come to the Bronx and be in your space. But you bring up a very important concept with 2 necessary comments. The first is, if you're following along with this, is it the drug or is it just the weight loss that's doing this? If you had anyone undergo a 10% or 15% weight loss, would they have these remarkable improvements in cardiovascular outcomes? The answer is no. The benefits derive before we see the weight loss. Moreover, we have a natural comparative, bariatric surgery, but we can effectuate the same amount of weight loss with some improvement from the risk factor, but not yet this demonstrable improvement in outcomes. And I know you have a large bariatric program here, and I'm not discrediting that, but I'm saying that biologically, when we get to weight loss using these GLP-1 receptor agonists, we see different outcomes than when we get their independent movements. So that's the first comment. But the next part about this is, can we accomplish this thing through non-pharmaceutical genes, that is, to change diet? I think you're onto something. Because part of what happens, particularly to type 2, is that we evolve insulin resistance. And so there clearly are foodstuffs, particularly high density foodstuffs, that do generate more insulin resistance than other foodstuffs. Conversely, when we do the things that we talk about in the age like fiber and food, then we reduce some of these signals, because remember, it all starts with the infant release. And so if that release is less robust, and if the diet that we take in with fiber and vegetables doesn't lead to such dramatic peaks and valleys in glucose, then the a priori insult disputes. Louisa.
Thank you. Always inspirational to assist your lecture as usual. 2 questions. Number 1, I had to do analogy with, we feel I know better. So when I look at stroke prevention for atrial fibrillation, despite the warfarin and then the NOAC introduction, we still have miscompliance, people that don't take the show us patient, because we know you're going to have a stroke, but people don't get it and they get a stroke. So what is your idea about people have to be on, number 1, and then how people will be compliant in always taking these drugs?
So if I give the answer, is a very important question. And it has to do with implementation science. Meaning, these drugs work so well, and we're already challenged with things that are inexpensive and readily available. How can we possibly imagine that this approach would give us an advantage? And that's why I use the word implementation, because realize the way in which we're dosing semaglutide right now is with weekly injection. The fact that it's a parenteral approach obviates this day-to-day necessity for adherence. The fact that it can be scheduled is a nudge that allows patients to stay compliant. And let's not be silly. Everybody wants to lose weight and be more lean. And so you're taking a drug that makes you feel more aesthetically at ease. And so people continue to use it. But behavioral economists would say we're using a nudge aspect of the therapy that fosters compliance. And we're making it not daily, but weekly. And what happens down the road when it no longer has to be weekly, but can be monthly? So that's beneficial. Now, we don't know a priori if it participates in primary stroke prevention, but for secondary stroke prevention, it does. I mean, it gets us to another point. This is why biology is so important. You and I think about dosing the DOACs because we know that the anticoagulation retards the likelihood of stroke from embolic sources. But you and I both know that stroke is in part embolic, but part of it is prothrombotic. That's biology. And so if these agents are changing the biology of clot formation, and we know that insulin is prothrombotic, you can begin to understand where I'm going with this. So we may be getting to a very different mechanism now about stroke mitigation that we haven't explored before.
Thank you. And the second one is, you are one of the strongest supporter of, diversity and inclusion. Do we have data about, this medication is used across the board, or, there are, diversity data out there that, I think this hospital can contribute to?
So this is a really important conversation, and I hope that all 105 in the virtual space and all 150 in this space are with me for the next several comments. This is not only the challenge, this is the shortcoming. In the SELECT trial with 17,000 patients, 4% were either Black or African American or of African origin. 4%. So we really don't have the data that these benefits extend to people of African ancestry. That's a shortcoming. Secondly, the retail price for these drugs is $1,000 a month. There's just no patient population I know that can sustain a $12,000 a year therapy. And that's particularly challenging in populations where obesity is particularly rampant. Getting back to Mario's question, obesity is rampant in the south side of Chicago, in some areas of the Bronx, not because of people's behavior patterns, but because of what society provides for them, what foodstuffs are affordable and readily accessible. So our society predisposes people to obesity, predisposes people to an insulinogenic platform, predisposes people to dysglycemia. And now we have an effective way of treating it, and it's priced out of range of a condition that society invoked on people without their express spirit. So you're getting to something that, for me, goes beyond science and gets into advocacy. But that's the specific answer to your question. Yes, sir.
Thanks. That was a very thought-provoking and forward-thinking talk. But I want to kind of build upon your second point that some of the medical economics of this is that if you look at the cost of the drug and the number of people that have been given to it, could break the healthcare system. And we're still working on Medicare approving weight loss drugs. But when we get there, what can we as healthcare providers do to advocate to lower the cost of these drugs so when people that need to get it can get it?
So very important questions. None of us can pretend to have the answers, but let me just restate the question for everyone, particularly those online. The greatest challenge here may in fact be medical economics. Let's be clear. The cost numbers I've already articulated. What are our solutions? We as physicians forget about the power that we have. We are the prescribers. We have the ability to speak up and say, this is too expensive. I am not reluctant at all to put this in writing as editorial commentary. And I know that works. Why? Because collective voices reduce the cost of the PCSK9 inhibitors by 50%. Because leaders in cardiovascular medicine stepped up and said, this is not acceptable. And we're working stridently. The next session, I will be on the front row for this. You're talking about therapies for amyloidosis. The science is brilliant. The cost is obscene. And we are, again, advocating hard to say you cannot invoke a cost profile such as the current drugs for amyloid, TTR, on a population that is uniquely at risk, which is the population that can't afford it. And so in this case, we have to exercise our power. We have to realize that we control the flow of these agents by our prescriptive authority. But the other thing we have to remember is that all of this is a downstream intervention for an upstream problem that we can help address. I mean, the problem here is medical obesity. Let's peel away the cover. It's not the $1,000 a month. It's medical obesity. And it starts in childhood. If we were incentivized to really focus on lifestyle as a medical condition, it would change. What we're doing in the American Heart Association is a very unique effort called Food is Medicine, where we envision writing a prescription for a diet that an insurance company reimburses, a prescription for a diet that prevents you from developing obesity. And you never need to get the $1,000 a month drug. So that's what we can do.
Okay.
So, Clyde, really heartfelt thank you for coming here. Clyde's also at New York Valves today, but he's going back and forth to spend some time with us. He could be anywhere. And you're here today and was really fantastic. We'll take a break now for about 25 minutes. Go visit the exhibitors, please. And we'll come back in here at 10:25, 5 minutes later than in the program.
Okay, so I'm gonna be moderating, but I already sent the presentation to Stacy. I don't think send it to you.
So with the presentation on is the one that.
Yeah, we sent that, I sent like a few changes. I send it to Stacy. Hopefully we can send it to him so we can change this.
Yeah, we can check with him, because he's the one that has it.
So money is made by. Hey, how are you, man? Nice to meet you.
Hi, how are you?
I'll just pleasure.
I just got the email.
Okay, perfect. So
I'll switch it.
I'll tell you, because there's two presentations that says.
Yes.
Let's take a picture. Hold on, we need just bring move the Chicago with us.
Okay.
Yes, yes. Just we have to. Yeah. We can go. Yeah,
Maybe you can. Yeah. When you're ready, because you're like.
Every part of this whole auditorium, he's not working.
Is it good? Is it good? Is it good?
Perfect.
No, that's what I'm saying. We're redoing the whole auditorium.
Yes,
Right now, the
this is-
system is not fully functioning.
Closer, closer.
You need to put that microphone is there.
But which microphones that you don't hear? You hear the speaker?
You have to switch the word.
Okay.
You're switching to this camera. Okay, good.
Okay.
Oh, see, we have more.
Voice.
I mean,
Okay.
yeah, because I mean, you already has one here, but then if we're moderating.
Yeah.
What about this one?
Dalia.
Would this work? Yeah.
Yeah, this one was. USB mine.
Le envié
Can we put it on top of it?
hace para.
No, puse.
Estamos live on Twitter, estamos conectados.
There's some right here.
I think this is perfect.
That's the podium. Okay, better. Because it was like. Next to you.
We're getting a hang of it.
I just checked it there.
Okay, great.
All right.
Were you guys?
Huh?
You can done well.
Yeah.
Just making some adjustments.
One, two.
Sorry.
Oh, God.
Thank you.
Let's have a coffee.
We're going there just. I'm gonna be moderating, then we have no time. Remember, if there isn't the.
Okay, so you want to switch.
So the,
You guys have one there. right?
one, yes, exactly. So then you
So
can
let me
check
let me
out,
download.
download the one first.
Going smoothly.
It seems, how does it seem
It
from
seems
the background?
seamless, yeah,
Uh,
except for the one person who's having difficulty hearing.
Yes, we have one lady who,
She's complaining on.
I don't know what to do. 1 second.
So
Hold on. And then you don't need more than 2 seconds.
Right, I think I only.
Be seated. We're going to start in a minute or two.
There's a microphone should be close.
The best engineering show that I can you have to be close to the mic. Sometimes the best is on the side.
The best way would be to just bring them together and do it with Batiklia on the side. Then you will have to switch with the
Okay,
camera.
so stay here.
But if you stay here, then you keep the mics like this.
Okay, Mario, let me briefly step here to introduce you. Okay, we're going to start back up for the next session, which will focus on infiltrative cardiomyopathies. And it's really my pleasure to silence all of you and, and very briefly acknowledge Dr. Garcia, Mario, who is a division chief. I have been here now for 10 years. And I have to say, under Mario's leadership, it's really the heart failure division, the EP division, and interventional cardiology independently have become, I think, 3 globally recognized teams. And this is because Mario followed a very good approach, which is hire good people and get out of the way. And that's what you've done. And Mario is really a fantastic leader for us. And you can just see it. And the team has now, I don't know, 300 publications a year. This was, I think, 30 when you came here, has built an incredible division of cardiology. And we're on our way to the top 20, hopefully, in the United States very soon, to then come and chase Northwestern down somewhere. The topic of Mario is imaging approach to the infiltrative cardiomyopathies. And I asked him to do this because he recently also authored the American Heart Association guidelines on this. So I figured there's no better person to speak to us about this than the person who sends the global guidelines. Thank you, Mario.
Thank you, Uli, and thank you for showing your gratitude by having me speak after Dr. Yancy. So after that lecture, everything is going to go downhill, starting with me right now. So I promise you, I'm gonna get you very confused with this talk, and that's intentional, because what I wanna do is have my colleagues afterwards make it clear for you, so you have to stay here and listen to the entire program. Infiltrative cardiomyopathies are a group of diseases that are characterized by deposition of abnormal substances in the myocardium. That infiltration can be inside the cells or outside the cells. That one, as you know, are called myocardial storage disorders as well. They can cause systolic dysfunction, diastolic dysfunction, more often than not both, and they can lead to heart failure and, of course, to premature death. If you look at all the causes of heart failure, they account for about 5% total, but those are particularly the ones that are key to recognize early in order to identify solutions that can be effective for the patients. One thing that has changed over the time is that we have been learning that the morphology of these storage diseases can vary a lot. Many of them will present with a restrictive morphology, with a small abnormal left ventricular cavity size, normal, reduced, or increased cardiac mass. And universally, they do have, however, impaired diastolic function. Some of them will present with a dilated morphology, with an enlarged LV cavity and reduced ejection fraction. And in fact, some of them mimic hypertrophic cardiomyopathy with symmetrically or asymmetrical increase left ventricular wall thickness, findings on the electrocardiogram that are identical to the ones to see in hypertrophic cardiomyopathy, and of course with a small or normal left cavity size. This is a patient that I saw when I used to be a member of the staff in the coronary care unit. Thank you for relieving me from that duty, Dr. Yordi. And that lady presented here with heart failure symptoms that were very, very difficult to treat in the first few days. She had a history of lupus, and she had end-stage renal disease. You can see that there's a floating thrombus in the apex, and we say, well, this is a typical case of dilated cardiomyopathy, maybe a myocarditis, but one thing that is key is that we look at the Doppler and we see a restricted filling pattern. Now, I can tell you, when I am on Tuesdays or Fridays in the echo lab reading, I get a lot of phone calls. The PAs call and they want to know what is the ejection fraction of this patient. The residents and the fellows call and they want to know what is the ejection fraction of that other patient. The attendings in the CCU call me and they want to know what is the ejection fraction in those patients. But nobody asked me, how is diastolic function? I want you, if you remember one thing out of here, to ask once in a while, what is the diastolic function? So obviously this is quite abnormal and has important significance beyond what you see on the simple number of ejection fraction. This lady had a biopsy and she ended up having hydroxychloroquine toxicity, which is not so uncommon. Plaquenil can cause heart failure and presents in many, many different ways. And it's an intracellular accumulation of glycogen and membrane phospholipids, which is an acquired form of infiltrative cardiomyopathy. Now, many years, I was a young fellow when we published this paper, and still represents the basis of what we do today. The analysis of diastolic function relies primarily on Doppler, and we use conventional pulse Doppler in the left ventricular filling and tissue Doppler, which we measure in the septum and the base of the lateral wall. And we look at the pattern to identify whether the diastolic function is abnormal or not. And that tissue Doppler is critical. Studies have demonstrated that the lower the tissue Doppler velocity, the velocity of movement of the myocardium in the long axis in particularly, it correlates with the deposition of collagen and other substances in the myocardium that impair the normal function of the cardiomyocytes. In addition to that pattern of abnormal relaxation that we have in patients with diastolic function, we have also abnormalities in left ventricular compliance. And just to remind you, compliance in a normal individual versus a patient with HFpEF or HFrEF basically indicates that for the same amount of volume, there is disproportionately high increase in left ventricular pressure. And if you look at a curve of the HFpEF patient in particular, you can understand why a little too much diuresis put the patient into kidney failure because of a low stroke volume, a little too much fluid, or holding diuresis put the patient in pulmonary edema. We can measure that with Doppler as well. We can look at the deceleration time of the mitral E with the early filling, and that short deceleration time can be related to the compliance of the left atrium and the left ventricle. And this is work that we did with Jim Thomas when we were at Cleveland, who's now working with Clyde, probably the most important mentor in my career. But certainly looking at this pattern tells me a lot of information and also predicts what's going to be the long-term outcome of these patients, independent of the ejection fraction. When you look at patients with dilated cardiomyopathy, or if you look at patients with amyloid, the same, when you have a short deceleration time indicating restrictive filling pattern, prognosis is much worse than when your deceleration time is normal. Second case, here's a 56-year-old man with diabetes, dyspnea, and murmur. I think this is a patient that probably was referred to Dr. Latif to see if we can put a clip on that mitral valve, but that left ventricle is bigger than my head. So in that particular situation, you know that a clip usually doesn't work that well. You need to do that when the ventricle has a smaller dimension. So we do start looking for other causes of LV dysfunction, and we did an MRI on this patient. And this is a SSFP CNS sequence, the standard sequence to look at left ventricular contractility. And you can see contractility impaired, but you can also see some other characteristics in this image here. I'm going to discuss that in a minute. And with that, I'm going to go to my first question. Which one of the following cardiac diseases is not associated with LGE, with late enhancement on CMR? I got it. Fabry's disease, light chain amyloidosis, Leffler's disease, sarcoidosis, or hemochromatosis? Which one of these doesn't give you late enhancement when you inject gadolinium on an MRI? Look, more of a question to the imaging faculty in the audience. Okay. 30 hits. Are we getting the results here? Right. Oh. Wild guess. So the so the answer is actually hemochromatosis. Hemochromatosis. So one thing that should have raised your clue, look at the color of the liver. It's pitch black. So if you compare that with the skeletal muscle, you see the trapezius on the image, which is gray. The myocardium and the liver are nulling very fast. Basically, the content of iron is actually making the magnetization going back immediately to baseline. And that's why you measure with the T2 star sequence. And actually, you can actually quantify the amount of iron with the MRI. And the image on the center show image after gadolinium showing no enhancement. For whatever reason, there's no fibrosis in patients with hemochromatosis. It's basically the iron deposition, which is toxic. Now, studies primarily done in England have shown that you can actually quantify better the amount of iron with MRI than with ferritin levels in order to identify how severe is the deposition of iron. And if you have a very short T2 start time of 10 milliseconds or so. That's the best predictor of development of heart failure and also arrhythmias in these patients. We don't have many patients with thalassemia here in this area, but we studied a few years ago a population of patients with sickle cell disease. They don't get iron deposition as much as thalassemia patients, but those that have very severe crisis and have received multiple blood transfusion tend to get it more frequently. So here is a study where we actually measure the function of the myocardium using strain imaging with ultrasound and compare with the T2 start times on MRI on these patients. And what we found basically, as we predicted, that the more iron that you have, the less is the contractility of the myocardium in these patients. Now, what we know the most, what we are more used to, is the use of late enhancement in patients with cardiomyopathies in general. And initially, it was studied primarily to evaluate patients with ischemic cardiomyopathy. Shown on the left, you can see the typical ischemic patterns. You can see late enhancement, which is that white area, in the distribution of a coronary artery. So this is a pattern of an LAD infarct. At the top on the left, you see a subendocardial enhancement. Ischemia always affects first the subendocardium. And if you add a transmural infarction, you can see that that area occupies the entire thickness of the wall. Non-ischemic patterns that occur in about 40% of patients with dilated cardiomyopathies can have mid-myocardial, subepicardial, or patchy distribution, but they are different than the ones we have in ischemic cardiomyopathy. So one of the roles of late enhancement in these patients is to exclude ischemic cardiomyopathy as an etiology, but also to help you with prognosis. This is from a cohort of patients with reduced ejection fraction that we studied when a little bit before I came here, when I was at Sinai, and basically the ability to identify late enhancement in patients with dilated cardiomyopathy was associated with a worse prognosis than patients with dilated cardiomyopathy with the same low EF, but who did not have gadolinium enhancement on MRI. Now, if you look at one of the modern MRI reports done by Dr. Shannon here, you will see T1 time, T2 time, T1 weighted, T1 mapping, T2 mapping, T2 star mapping. What are all these things? There are different sequences that are used to actually color and code different areas of the myocardium with a particular magnetic properties. And obviously, we can measure many factors and help identify different pathologies using these techniques. T1 mapping, probably the one that you would see more commonly utilized, is based on the longitudinal relaxation, basically the protons aligning with the direction of the magnetic field. And it basically, thing to remember, it's increased when you have edema and you have less signal. And you have that in acute myocardial infarction, in myocarditis, when you have increased extracellular space, like in amyloidosis. And of course, is decreased if you have dense, compact myocardium, or you have something very magnetic like iron, like in hemochromatosis. So here's an example of a patient with hemochromatosis on the left with a very short T1 time, and on the right, a patient with amyloidosis with a very long T1 time. And those are the typical T1 mapping images that you will see shown. Now, many of you have seen this already. This is a strain imaging, which is done with echocardiography. If I remove the color from that image, it would be difficult for anyone here to say, what is the pathology here? But putting that strain mapping, it makes it a little easier. You can see that the apex of the heart, and you see the curves at the bottom, that apex is contracting more than the mid and the basal segments. And that is typical of one condition, which is cardiac amyloidosis. Now, this is the typical amyloidosis pattern: increased wall thickness, small LV cavity, dilated atria, more pericardial effusion, and apical sparing on the strain pattern. Basically, that pattern where the infiltration of the myocardium, for some reason, gets late into the apical segments, and it starts first at the base and moves towards the apex. Now, we have relied on that very often to make the diagnosis, and we use a strain imaging, which is important in echocardiography to evaluate the left ventricular contractility. But a strain imaging is also important. It's becoming more important to look at the left atrial function. So I want to show you here a normal individual echocardiogram on the left and an abnormal on the right, and pay attention to the left atrium. And you can see how this left atrium, which is smaller, is changing its size constantly through the cardiac cycle, whereas in the amyloid patient, the cavity is dilated, but it's not moving that much. And this is a patient in sinus rhythm. So reduced left atrial strain is something that we have seen more and more characteristics in patients with infiltrative cardiomyopathies, in particular in patients with cardiac amyloid. And that can be measured very simple from ultrasound images that are recorded in any electronic format. The more reduced is the strain in patients with preserved ejection fraction, the higher is a measured pulmonary vascular resistance, indicating higher filling pressures in the patient, more decompensated heart failure. And when you have an LA reservoir strain that is reduced below 30%, the event-free survival is much worse than if your left atrial strain is preserved. And this is something very important that was published a year ago. This is from a large cohort of patients that were studied, that were enrolled into a prospective trial, observational study to determine the prevalence of a stroke and the causes of a stroke. And when they analyzed the original echocardiograms that were performed, having a low strain was associated with a high incidence of embolic stroke. And it makes sense. If you have a left atrium, even in sinus rhythm, that doesn't contract a lot, more likely that you're going to form a clot and more likely that you develop a stroke over time. So it has implications. You have that amyloid patient, which is in sinus with a very reduced left atrial strain, consider anticoagulation for that reason. MRI is also used in amyloid. The typical MRI pattern shows abnormal kinetics of the gadolinium after injection. So it's difficult to wash out the gadolinium from the blood pool, and you cannot differentiate very well the myocardium from the blood pool. So here is not white and black, it's gray and darker shade of gray. You also see this subendocardial enhancement and left atrial enhancement in these patients. But today we rely more on the Perugina score. I'm sorry, the Perugini score. I got to show you the Perugina because you can rate your chocolate, different levels of cacao from 50 to 70 to 85. The Perugini score does the same, basically compares the use of technetium pyrophosphate, which is an analog of that is used also for bone scanning, in the bone compared to the myocardium. And the more that you have enhancement of the myocardium, the more likely that you have the diagnosis of amyloid. So Perugini 0 on the left, 1, 2, and 3 on the right. Score of Perugini 3 has a high specificity for amyloid. It's not exclusive of TTR amyloid. You can see sometimes in AL amyloid, scores of 2 and 3, the sensitivity specificity is intermediate. And here I can show you that unfortunately, you not always get the diagnosis right with imaging. So here we have something that looks a lot like amyloid. Increased wall thickness, apical sparing on a strain pattern, abnormal PYP deposition, yet this patient has also a plaquenil-induced cardiotoxicity in a different morphology. This is a restrictive morphology. So there are many mimics, and imaging is not always able to tell you for sure the diagnosis without aiding other factors. So Over time, biopsy has been replaced more and more by imaging. You can see here in amyloid, the number of the proportion of biopsies versus PYP scans. And you can see that over time, PYP is used more and more frequently to rely on the diagnosis of amyloid. Here, I show you another case. This is a 36-year-old man with dyspnea, CKD, and syncope. Looks pretty much like a pathology that Dr. Shannon will discuss later, right? We see thick walls, a small LV cavity, and systolic anterior motion of the mitral valve. Hypertrophic cardiomyopathy, yes? No, it's not. This patient has another condition, and the keys are the CKD and the history of syncope. So next question, which of the following cardiac diseases characterized by intracellular storage rather than extracellular? Fabry's, light chain amyloid, Loeffler's, sarcoid, or primary restrictive cardiomyopathy? There's some music. Yeah, all right. All right. Again, well, majority gets right. This is Fabry's disease, and Fabry's disease is the one in this list that is an intracellular deposition disease. So other things that you see in Fabry, which is an X-linked storage disorder that affect multiple systems. So when you have a patient with apparent hypertrophic cardiomyopathy, but has other neurological and renal manifestations, think about Fabry's. It has caused by a DNA mutation that results in accumulation of global triacylceramide by the enzyme deficiency of alpha-galactosidase, and it causes neurological manifestations, including syncope and stroke, as well as renal failure. You can see on this image that there's also a pattern of FDG deposition, which is predominant in the lateral wall, which is different than what you see in hypertrophic cardiomyopathy. You can see also late enhancement in the lateral wall on MRI, and that for some reason is more characteristics of Fabry. Just to remind you, as I'm introducing here another imaging technique, which is FDG PET, that the preparation, dietary preparation for PET for measuring inflammation or the storage diseases has to be very different than the preparation that you use for a patient with ischemic cardiomyopathy. Here, you want to use a ketogenic diet followed by fasting. So there's avidity for glucose that is given at the time of the injection. So just to remind you, there are many glycogen storage diseases that mimic hypertrophic cardiomyopathy, and it's therefore important that imaging is never taken alone, but also in consideration with genetics, as well as with metabolomics. Another case here, 51-year-old woman with palpitations. You can see here frequent multifocal PVCs. At an echo that shows a dyskinetic segment at the apex. Turn around, also has a basal posterior aneurysm. And that leads to question number 3. What would you do next in this patient? A coronary angiogram, myocardial biopsy, cardiac MRI, a PET with ammonia, or a PET with FDG. All right, 1, 2, screen. Ah. I'm disappointed. You have a patient with regional wall motion abnormalities. The first thing you do is a coronary angiogram, right? Right? You have to make sure that you don't have ischemic cardiomyopathy. The patient has aneurysms or so. This patient has normal coronaries, of course. And obviously, you can do CT angiogram as an alternative to coronary angiography. In many of these patients, the probability of CAD is not high, but certainly with regional wall motion abnormalities and aneurysm, you have to make sure your coronaries are normal first. Now, this patient had an MRI that showed mid-myocardial enhancement in the lateral wall, has a PET with ammonia, which is a perfusion agent showing decreased perfusion in that area, and a PET with FDG that show increased signal indicating inflammation in the same area where there is the reduced perfusion. So what is the diagnosis here? Sarcoid, right? No, it's actually Chagas disease. Yeah, so that would be 9 out of 10 times Sarcoid or more frequently. But just to remind you, not always imaging will give you 100% the diagnosis. Imaging will lead you to establish the diagnosis by choosing the appropriate pathway together with the clinical manifestations of disease, the progression, the involvement of other organs, and then complementary serologic data as well as in many often information that you collect from cardiogenetics. So there are specific protocols that you can follow, starting with echo, looking if there's increased or normal wall thickness, and moving down to the findings on the EKG, biomarkers, and the cardiogenetics. And in summary, you should spare an infiltrative disorder if you don't see an identifiable cause. You have rapid progression of disease, poor response to heart failure therapy, and other systemic manifestations. Cardiac imaging is essential for guiding the diagnosis, establishing prognosis, and monitoring response to therapy. But establishing the diagnosis in most cases will require integrating the clinical ECG, cardiac imaging, metabolic findings, genetic findings, and often myocardial biopsy as well. Thank you.
Well, that was a tour de force with cardiomyopathies and the use of imaging. Thank you, Garcia. I mean, I think it's phenomenal how you highlighted the high index of suspicion that we need to have for these patients, and the fact that we should not just stay with just the normal EF, normal side ventricles for thinking into cardiomyopathies. I think we need to expand the spectrum for even those that are kind of a little dilated and maybe with low EF, and look for other more details in all the images that we have. So feel free to come here to the microphone if you have any particular questions. The same for the phones that are online. We're here monitoring the Q&A kind of chat. So to meet your questions, so we can present those to Dr. Garcia. So maybe I start with one. So how do you go about, let's say, MRI in patients with perhaps that's a little dilated and decreased ejection fraction? You send everyone to MRI? How are you going to go about in your clinical practice?
I definitely do send practically everyone to MRI these days, unless there are contraindications, unless the patient has decompensated heart failure and they cannot lay for what you need to do about 30 minutes flat while you're getting the scanner done. So don't send a patient from the CC, you get an MRI. That's not going to be very helpful. You send the patient after the patient has been stabilized medically and now they're compensated, because it's a very rigorous examination. And you know very well, there are so many things that you can do on MRI that if you want to do all the sequences and all the measurements, you can have a patient for a whole day inside a magnet. You have to have a high index of suspicion to know what are you looking for to simplify the study and try to get it within 30 to 60 minutes. There are many centers that are using AI right now to actually simplify data acquisition and the measurement of the parameters that are necessary to make the diagnosis that can result in MRI studies shortened to about less than 30 minutes. Ray Kim from the Brigham is pioneering that.
Any questions from the audience?
Yeah. I'm not sure this is working.
Okay, welcome.
Yeah, just wanted to speak because the Zoom count went up, so you did pass the test and speak up to Dr. Yancy and Zoom went up. ICD and MRI. It's just something for the outside people and people here. Just to a few words on that. Is that a possibility now? Is that still a no-go?
Yeah, most of the times we can do MRIs on patients with pacemakers, the ICD units. The leads that are implanted today are mostly compatible. There are some older leads that are not compatible, so you always have to find out when the device was implanted and what are the characteristics of the device that you have. Yet, even when compatible devices, sometimes you get artifacts on the images that make the quality sometimes restrictive. But when necessary, I think is an important tool and can be done.
Just repeat the questions, better for resumption.
Thank you for the great opportunity. Can you comment on about heart failure patients with improved ejection fraction? For them, does the cardiac MRI should be done? Does it even matter if the EF is improved?
Well, that's a very good question. I think what you're getting at is the possibility. The question is what could be the potential role in patients with improved ejection fraction? Patients that present with reduced ejection fraction are treated, and now the ejection fraction normalizes. And I think you're getting at the possibility of using imaging, particularly MRI, to identify patients that can be weaned from therapy, at least partially. I think that's something that should be explored in the future. I don't know that I have the answer to that.
You have a question from the audience? Okay, one last thing I just want to hear your comments is, I mean, that last case that you're going to take us all in terms of the sarcoid, that case was sarcoid. I wonder if there was a possibility for an option to have a PETMR. So the complementary value of PETMR, and we have that now available to MonteHeart. I just want to hear your comments.
Well, the patient had a PET and the patient had an MR. The advantage of a PET MR is that you get the two-in-one in one sitting, and you can get a little better registration of findings with that. I think this particular case probably would have been giving you the same results, whether you have done it separately or together. I wanted to show that case just to remind you that sometimes we react immediately to the findings on imaging and start patients on treatment, and when we not necessarily have 100% the correct diagnosis. And imaging should be good to actually guide us. And if the patient had granuloma somewhere else, and we can do a biopsy on the granuloma and prove that it's sarcoid, then we have the diagnosis, and they will have the ability to start the appropriate therapy, which is very different for sarcoid than for Chagas.
Perfect. Thank you. Before I introduce the next speaker, I'm just going to make an announcement that there will be a special monthly presentation for lunchtime. It's going to be Okay, so we have Dr. Torres here, who's gonna speak to us about all the novel and new therapies for TTR amyloid, being an explosion. Dr. Torres is an assistant professor of medicine in clinical medicine, and he's the director of the amyloid clinic here at MonteHeart. So, Torres.
Right. Thank you very much, Aldo. So these are some disclosures, kind of boilerplate type stuff I'll let you take a look at. So Dr. Yordi asked me to speak about this issue of gene silencers in cardiomyopathy, and I happened to see a patient relatively recently who I think illustrated many interesting aspects of amyloidosis care, so I wanted to share this patient with you. So it's a 72-year-old male with known amyloid cardiomyopathy, TTR cardiomyopathy, and he comes to me for a second opinion. So he has hypertension, he's had diabetes for 30 years, he has BPH. Amazingly, he has no cardiovascular complaints. He has no prior smoking or drinking, anything like this. He's originally from Antigua. And this is the workup that he had before he met me. So in 2021, he had an abnormal EKG. He didn't have any complaints per se at the time. And then he had a pretty extensive workup. So he had a exercise stress test, and you'll note he did quite well. He did 9 minutes on a Bruce protocol with a normal perfusion. And then also on an echo, he had moderate LVH and a low ejection fraction. So a couple of years later, he ended up getting a cardiac MRI, a technetium pyrophosphate scans, both consistent with cardiac amyloidosis. And they did a monoclonal protein assessment that was negative at the time. And then the preceding cardiologist appropriately started the patient on tafamidis. I just want to point out that there is kind of a common narrative of amyloidosis patients frequently initiating their evaluation and then ultimately winding up on treatment, taking a long period of time. And I think this is a good illustration of that. So we started in 2021, about 2 years later before the patient actually ended up on treatment. So here's the culprit EKG. Okay, so it's normal sinus rhythm with, if you'll note, low voltage in the frontal plane and a pseudo-infarct pattern in the inferior and anterior leads. And this is the technetium pyrophosphate scan showing myocardial uptake of the technetium. And this is the very characteristic echo findings of cardiac amyloidosis. So this is his echo with significant LVH, myocardial speckling, and a decreased ejection fraction in this particular case. So when I see him, things that I note about him, vital signs are fine. He's not frail and he's not cachectic, but he's very thin. Okay, and his BMI is 17.5. So we've been talking a lot about BMIs today. So this is very, very thin. He's a very pleasant guy, unremarkable cardiovascular exam. He's never had a prior heart failure hospitalization. So when I asked him and his wife about that, they looked at me like I was crazy. However, notable things that are somewhat distinct from many other patients I've seen, he's had 30-pound weight loss over the last 2 years, and he's had a lot of diarrhea. And he also has some difficulty with fine motor skills, so particularly opening pill bottles. He also had a difficult time with balance, okay? So this is the patient. I'm the expert, and the patient already came with a full evaluation and is on appropriate treatment. So the question is there anything else you should do with a patient like this? Is there any further workup to be done? So I'll just tell you the things that I found notable about him and the things I found interesting was this potential neuropathy. So I got an EMG, and we also did TTR genetic testing. So the EMG demonstrated a severe peripheral neuropathy, okay? And then the TTR genetic testing showed this mutation that I'd never heard of before. So you'll have to forgive me, but I kind of pride myself on knowing obscure TTR gene mutations. And this is one that I've never heard before. So I had to go to the literature to learn a little bit more about it. And prior to these 2 papers being published this year, there were 2 case reports about patients with this kind of mutation. These are 2 different registries. One is a large European registry, and the other one's a large international registry. Between the 2 registries, there's several thousand TTR amyloid patients. And I'll briefly summarize the findings of the registry, but both of these were describing rare genotypes. So 50 patients described worldwide in total. 80% of them were male, average age 60. Almost all were from France and Brazil. There was only one from the US. And they have, of these patients from the registry, they have predominantly either a neuropathic phenotype. We'll discuss this a little bit later, but either predominantly neuropathic or what we call a combined phenotype, which is cardiovascular involvement as well as neuropathic involvement. So in summary, we have a 72-year-old diabetic male with a known TTR cardiomyopathy. He's appropriately on tafamidis. He has very rare TTR gene mutation. He has very severe neuropathy. So just a brief word on TTR cardiomyopathy, and it's basically extracellular deposition in either the heart or the nerves of a misfolded protein called transthyretin, okay? So the heart symptoms of this would include things like heart failure, restrictive cardiomyopathy, conduction disorders, and in the nerves, you have autonomic dysfunction, erectile dysfunction, orthostasis, diarrhea, and constipation. Also peripheral neuropathy, typically in a stocking and glove kind of distribution, distal axonal problems, principally pain and sensory difficulties. And then there's hereditary ways to get this as well as wild type. So hereditary, I'll just tell you the Bronx experience. In my clinic, typically we have this V122 isoleucine, which is a very important mutation in African-American, African-Caribbean populations. Prevalence about 3 to 5% in those populations. And that's a very large amount of what I see in my clinic. And that's distinct from this particular patient. The other way of getting this is what we call wild type disease. So you don't need a gene mutation. So everybody in this room is at risk of developing TTR cardiomyopathy at very late stages of your life, okay? The population risk is quite low, so don't worry, but it's something that's going to affect you potentially very late in your life. So thinking about therapeutic strategies and also thinking about just the pathophysiology of TTR. So this guy, I don't know if you can see the cursor, but the green guy here, you can, yes. This guy here, the TTR is largely produced by the liver. And if it is destabilized by one of these gene mutations that I mentioned, or some other age-related mechanisms, it will unfold and it will deposit in the intracellular space in the nerves and in the heart. So there's three potential mechanisms to decrease that problem. So starting from the left, looking at the liver, we can decrease the production of the TTR, and that's the concept of TTR knockdown, and that's what the gene silencers do. So they interfere with the translation from mRNA to protein of the TTR. So it's a very novel mechanism, and they can decrease the circulating TTR typically by 80 to 95%, okay? And we'll get into some of the outcomes data a little bit later. Interestingly, CRISPR-Cas9, the thing that everybody's very, very interesting, just beginning, it's gene editing, and it's just beginning phase 3 clinical trials now. Looking at the TTR molecule itself, it can be stabilized, okay? So there's structure-based drug design compounds that basically bind the TTR and prevent it from breaking down. As such, it doesn't go to the right and it doesn't go into the target tissues. And then finally, there's an interesting new concept of fibril deposit. And so there's several monoclonal antibodies now in phase 2 and 3 clinical trials looking at removal of amyloidosis from the target tissues. So the treatment landscape, a couple of things to keep in mind is if I put this slide up 5 years ago, it would be a blank slide, okay? So all of these agents are very, very new and very novel, and the treatment landscape is evolving very, very rapidly. Briefly, there's several RNA inhibitors that are approved by the FDA for a predominant neuropathic phenotype, with the outcomes data supporting them through a functional outcome, functional benefit, okay? Conversely, tafamidis is a oral stabilizer that is FDA approved for primary cardiomyopathy, and that is approved based on a mortality benefit. So is there a role for RNA silencers in TTR cardiomyopathy? And I guess, let me go back here. And that's kind of the point of the talk. So there's a number of ways of approaching that particular question, okay? Should we be using, or will there be a future of using RNA inhibitors for a primary cardiomyopathy indication? And there's a number of ways of approaching that question. I think this is one of the more straightforward ways. And this is a randomized controlled trial published last year. And this is the Apollo B study. So 360 patients, both wild type and hereditary cardiomyopathy, class 1 through 3 heart failure. They generally try to get people with less severe heart failure. And the treatment was patisiran, which is a infusion that's given every 3 months versus, every 3 weeks versus placebo. They had a primary endpoint of a change in 6-minute walk test at 12 months, okay? And the final result is they demonstrated a significant improvement in 6-minute walk tests at 12 months. Now, the semantics of this is a little bit challenging when you're talking with patients or other providers, so I just want to demonstrate the data. And what you'll see here is this is the 6-minute walk test, and in blue is the placebo. And as you can imagine, over the course of 18 months, you progressively get, over 12 months, progressively get worse. Patisiran is in yellow, and you'll demonstrate that it's effectively like a stabilizing effect. It didn't improve the 6-minute walk per se. That would have been above that line, but it did have a statistically significant improvement in 6-minute walk test at 12 months with a mean difference of roughly 15 meters. There were some secondary endpoints as well, including an improvement in KCCQ. There was no improvement in mortality or cardiovascular hospitalization because the number of patients was too small and the follow-up time, of course, was too short. So it was not powered for that indication, for that endpoint. There were also some pre-specified exploratory endpoints. The changes of BNP, troponin, LV mass, and LV stroke volume on echo all demonstrated or favored patisiran in a manner that should be considered hypothesis generating. So the takeaway from the Apollo B study, I would say on the good side, this is a novel finding. There's never been a clinical outcome, a clinical endpoint that has been demonstrated to benefit with a gene silencer in TTR cardiomyopathy. So that was a good thing. When given the opportunity to consider it for approval by the FDA declined, citing a lack of hard cardiovascular endpoints such as hospitalization, mortality. Also, I guess an issue or a question is a 15-meter benefit of 6-minute walk test, is that clinically significant? It's statistically significant, but may not be clinically significant. And for context, the number that we typically would use for pulmonary hypertension study would be something like 33 meters, about twice as long. Now, whether we should be using that for amyloid patients or not is a matter of debate. So current TTR drug development, we have 2 silencers that are in large-scale randomized controlled trial now. So if you look over here, we have 2 RNA inhibitors. And if you look over here, the patient size and the duration of follow-up is much, much longer. And as such, the 2 studies are powered now for mortality and heart failure hospitalization, kind of like conventional clinical trials that we were accustomed to in the heart failure space. Both of these results will have sometime later this year and next year. So probably when I give this talk next year, it might be very different. So in summary, RNA silencer therapy remains off-label for a primary cardiomyopathy indication. However, subgroup analysis of several randomized controlled trials, as well as their open label extension, which we didn't get into here, demonstrate a favorable effect on endpoints such as BNP, troponin, LV mass, in a manner that should be considered hypothesis generating. And 2 large randomized controlled trials will give more definitive evidence on mortality and hospitalization endpoints. That's my talk.
I think it was kind of an amazing talk. And by the way, if you were wondering what the presentation one is going to be, so under the answers, it's going to be a great follow-up from these sessions. So again, if you have any questions from the audience or any online, please put your questions. So we have already got a question.
Yeah, actually, we're running a little bit, but 2 quick questions. One, in the stable experience, we found that I think it was several years before we really saw anything. That's correct. First year was also no difference in mortality in heart failure, so I guess.
Yes. So maybe a similar narrative to PCSK9, but I think it's going to take a certain duration to demonstrate benefit. So I think 2 major issues. One is the evolving patient population of TTR amyloid. So even going back to the tafamidis study, these patients were generally much sicker in later stage and probably easier to demonstrate a mortality benefit in. Rather than now, we have so much greater awareness, talks like this. So we're finding patients much, much earlier. So that's one issue. And then, yes, the duration is going to have to be substantially longer than certainly than 12 months.
And then just one line, and then there's a new topic, but CRISPR, TTR.
So that would be awesome. So I mean, it's just, there's phase 2 data published, phase 3 studies just beginning. If it works, I mean, CRISPR for this, for lipids, for you name it, and they just, of course, approved it just for sickle cell recently. So obviously what that would look like if it works is a one-time infusion, and that would be it, right? So there's, that's a big, big topic, obviously. But if it works out, we're gonna have a very different world.
in order to, as in your clinical practice, besides concomitants, are you using any other complementary?
It's interesting. Yeah. So generally not. I'm generally used tafamidis. I've had a handful of patients with significant neuropathy that I've attempted to get onto some of the silencers and have had some difficulty, and it's patient-oriented issues, things like that. And then there's all these very interesting off-label type things. So doxycycline, Tuca, and things like that, I don't generally have much experience with. Green tea extracts and things like this. I don't personally involve myself too much with those.
Okay, great. Oh, we have one last question, and so we can move on to
One last question. On the patient you presented, I mean, it's a very typical patient with hereditary mixed phenotype. So we would, in Spain, we would certainly put him on patisiran.
Yeah. So it's very funny. Yes. So Jose and I met many years ago in an amyloid meeting in Spain. And he's correct. And I'm sorry, the question was supposed to come through. I never fully addressed what's going on with that patient. So the patient wanted to confer with his neurologist about whether or not to start a silencer therapy. I would promote it. The confounding thing, and I think an interesting clinical point, is the patient has 30 years of diabetes and what can give you a very similar neuropathy, right? And then so how to make the distinction, you might have more experience in this than I. There's some issues some will report that there's benefit of skin biopsy, nerve biopsy. I think it's fundamentally a clinical decision. And my bias is to put him on this. So it's very funny. So that's my bias, but he's speaking with his neurologist and this is actually actively ongoing right now.
Yeah, if you're in doubt, you can do perineal biopsy, perineal nerve biopsy, which is very sensitive for TPR immune tools. And with all the dysautonomy, I'm sure that.
Yep. I agree.
Great discussion. So let's move on. So I'm going to have the pleasure to have Dr. Roshlani, who is the director of the Sarcoidosis Center here in MonteHeart, is speaking about standard of care treatment for sarcoid.
Right. Good morning. Thank you for having me. I think we've been, I've been tasked with talking about what standard of care, or rather a lack thereof, looks like for this challenging disease condition called cardiac sarcoidosis. So here are my objectives for the talk. I'm going to start with two cases and hopefully, take you on the journey that these two patients went on that kind of illustrates all the nuances and the challenges that we deal with in taking care of, this complex disease condition. So this is patient A. I've seen her in my clinic. She's 62, has a history of diabetes, presents with episodes of near syncope, and has an outpatient Holter that shows high-grade AV block. She's 62, has high-grade AV block that sends her cardiologist down the road of looking for conditions that would cause conduction system disease in somebody her age. She appropriately has a cardiac MRI that shows patchy LGE, late gadolinium enhancement, that is suspicious for sarcoidosis, and then subsequently has a PET scan that you see here that shows patchy FDG uptake, also suspicious for active inflammation. She also has FDG uptake in her mediastinal lymph nodes, which support an inflammatory disease, most likely sarcoid. At this point, she has a dual chamber pacemaker implanted, and she's referred to the cardiac sarcoidosis clinic here at MonteHeart. So I'm going to start with a question here for the audience. Hopefully I can do this correctly. So what would you recommend next for this patient? Would you start, now that you have a PET and an MRI that are both suggestive of sarcoidosis, would you initiate steroids? Would you do an endomyocardial biopsy to prove the diagnosis? Since she has mediastinal lymph node uptake, would you do a lung and lymph node biopsy? And would you first upgrade her pacemaker to an ICD? All right, so that's the right answer, and most of the majority of the people got it right. But as we go through the talk, we'll go through why that is the right answer. And the next patient, this is patient B. He's 57, obese with a BMI of 37, has a history of hypertension, diabetes, long history of arrhythmias, everything from atrial fibrillation to episodes of non-sustained VT, a high PVC burden. He's had PVC ablation before, AFib ablation before. Recently had an echo that shows an EF of 45%, which led to further workup with an MRI that shows patchy LGE again, inferolateral wall motion abnormality, and then subsequently had a PET scan that shows cardiac FTG uptake, but no extra cardiac FTG uptake, but suggestive of active inflammation in the lateral wall. He was also referred to the cardiac sarcoidosis clinic, and the question for him is based on the most recent 2024 AHA consensus statement about cardiac sarcoidosis. How would you classify his diagnosis? Is this definitely sarcoid, highly probable this is cardiac sarcoid, probable that this is cardiac sarcoid, or possible or low probability that this is cardiac sarcoid? All right, highly probable. So we'll talk through. So the right answer is probable, not highly probable. But as we go through the talk, we'll talk about why that is the case. So starting with what is sarcoidosis, why it matters, and when should you suspect it? It's a granulomatous inflammatory disease of unknown etiology. It affects women more commonly than men. It's typically a disease of middle-aged patients. So if you see someone who's 80 years old with a new diagnosis of sarcoidosis, you should always be suspicious that it's likely not sarcoidosis. The prevalence is higher in certain racial and ethnic groups, such as Northern European, African Americans, Afro-Caribbeans, and Japanese. Cardiac involvement, it's most commonly a disease of the lung and the lymph node. So 90% of the patients have lung and lymph node involvement. It's a small proportion of patients that have cardiac involvement. And more importantly, while a quarter of patients might have some sort of cardiac involvement, only 5% actually have clinically manifest cardiac involvement. It is important to remember that patients who have cardiac involvement, it confers a worse prognosis. The most common clinical cardiac manifestations are heart block, arrhythmia, or congestive heart failure. And even within the group of cardiac involvement, clinical manifestations can vary based on race and sex. So you see more heart failure in African Americans, more ventricular arrhythmias in men compared to women. So why does it even matter? Why should we worry about cardiac sarcoidosis more than any other non-ischemic cardiomyopathy that you would see in your practice? For a few reasons. So one is it's frequently misdiagnosed or underdiagnosed. And this is illustrated very nicely in this study from the Cleveland Clinic, where they looked at over 300 patients who underwent heart transplant over a period of several years. And they looked at what was the most common misdiagnosed condition in the pre-transplant group when they compared the diagnosis to post-explant. And sarcoidosis turns out to be was the most commonly misdiagnosed condition. So out of 13 patients in this 300-patient cohort who had sarcoidosis, only 2 were correctly labeled pre-transplant as sarcoidosis, and 11 were mislabeled. So it's frequently not really detected prior to end-stage heart failure. Secondly, the prognosis in this group is much worse compared to other non-ischemic cardiomyopathies. Prognosis with regards to their risk of sudden death, prognosis with regards to their risk of heart failure progression, and also the risk of arrhythmias doesn't always correlate with the degree of LV dysfunction, like we see with other non-ischemic cardiomyopathies. And lastly, and the most important thing, is if you catch this disease in time, there is hope. You can treat it. If you treat it timely with targeted therapies, there is a chance that you will prevent the LV function from deteriorating and you will reduce the risk of sudden cardiac death. When should you suspect cardiac sarcoidosis? So in patients who have unexplained AV block, who are under 60 years of age, which is where you don't typically see degenerative conduction system disease. If you see somebody with non-ischemic cardiomyopathy who has regional wall motion abnormalities, aneurysms, or basal septal thinning, idiopathic ventricular arrhythmias or sudden death, and in patients who have extra cardiac disease with some sort of cardiac symptoms such as syncope, near syncope, palpitations, or heart failure. Moving on to diagnosis. So before we go into our approach for how we diagnose this disease, I would like to highlight, this statement, which was recently published in April of 2024. It's a consensus statement that the experts in cardiac sarcoidosis have put together, but you can see that they have prefaced it with this, with these sentences here, which basically state that there is a lack of randomized control trials in cardiac sarcoidosis, and all the diagnostic and treatment strategies are based on cohort studies or consensus opinions. And even within the group of experts, there's substantial variation in how they approach this disease. And the consensus document actually says that although unanimous consensus on all elements was not possible, they aim to deliver the highest level of agreement that was possible. So here is our approach, and this is in line with what the experts recommend for how we diagnose cardiac sarcoidosis. If you have a clinical suspicion for the disease, the initial test of choice, of course, after ruling out coronary disease, like Dr. Garcia demonstrated, would be to do a cardiac MRI. If the cardiac MRI is suspicious, if the cardiac MRI is negative, is completely negative, and the likelihood of this being cardiac sarcoid is fairly low. There is a very small group of patients where you still suspect it if there's a very high clinical index of suspicion. But usually, if it's someone you're screening for cardiac involvement and the MRI is totally clear without any LGE, without any LV dysfunction, the likelihood that this is cardiac sarcoidosis is extremely, extremely low. If the MRI is positive, then you have to stop and think about, does this patient have extracardiac sarcoidosis, or is there any evidence that they might, or if they don't? If they do, then you could do a cardiac PET and look for inflammation in the heart and decide whether or not to treat. The second thing is, if they don't, if there's no evidence of prior history of cardiac sarcoidosis or extracardiac sarcoidosis, then you should consider a whole body PET to look for the disease outside of the heart, which will help you get to a tissue diagnosis. And, as Dr. Garcia very nicely demonstrated in that case with Chavez, always search for a tissue diagnosis. This is critical because you don't want to commit these patients to a long-term therapy, which has a lot of risks, without actually being confident in what you're treating. So here are the two most commonly used imaging modalities. Here are the pros and cons of each. We do have, like Dr. Shinoni mentioned, PET CMR now at MonteHeart, which is amazing because for patients that you're suspecting cardiac sarcoidosis, they can have both tests at the same time, and they are complementary to each other, and they actually help you, improve the credibility of each one of the tests. Cardiac MRI helps with diagnosis of fibrosis and edema. It's very sensitive. And it also helps you prognosticate because the degree of LGE correlates with the risk of ventricular arrhythmias in these patients. It also helps you give additional diagnoses that you might not be thinking of if it's not sarcoidosis. It can be challenging if you have an ICD, like we discussed. PET scan helps you detect active inflammation. The dietary prep part of it is extremely, extremely critical. It helps you follow response to therapy. And more importantly, it can help you get to a tissue diagnosis. The other key point here is endomyocardial biopsies, as easy as they are to do, the likelihood of getting something is very, very low because of the patchy nature of the disease. So how do you establish the diagnosis? It's critical to remember that sarcoidosis is, to establish the diagnosis, you need a combination of clinical, radiologic, and histologic features. There are three main societal guidelines or criteria that we use, which is the HRS criteria, most commonly used in the Heart Rhythm Society criteria, most commonly used in the United States. There is the Japanese Circulation Society criteria, which were updated in 2017, and then the World Association of Sarcoidosis and Granulomatous Diseases criteria. Of the three, they're pretty similar, which require tissue diagnosis, imaging findings, and clinical findings. But of the three, the Japanese criteria were updated in 2017, and there is a subcategory for what is called isolated cardiac sarcoid, where you're not able to get a tissue diagnosis, and you only have clinical and imaging features. The AHA consensus statement has tried to classify this a little bit differently to make it a bit easier for clinicians based on the approach that is commonly used in clinical practice to subcategorize this into definite, which is, you have cardiac histology positive, highly probable, which is extra cardiac histology plus clinical plus imaging cardiac findings, probable, which is clinical and imaging findings with or without extra cardiac histology, and then possible or low probability. How do we manage this disease? So management essentially is who to treat, how to treat, right? So in terms of who to treat, it's patients who have clinically manifest cardiac disease, and how to treat is in addition to the usual management for heart failure and arrhythmias, which would be, ablation therapies, GDMT for heart failure. There is also a role for immunosuppression in patients who have active cardiac inflammation. Immunosuppression, these are the 4 lines of therapies that we use in these patients. It's important to remember that this is all expert consensus, that there are no randomized clinical trials yet, but there is an ongoing randomized clinical trial right now, which is looking at the optimal strategy to, what sort of therapy should you start these patients on? Should it be glucocorticoids alone versus glucocorticoid for and a second line agent such as methotrexate? The other important thing about, in addition to immunosuppression, that is different about sarcoidosis is thinking about the risk of sudden death in these patients. The risk of sudden death is not the same as any other non-ischemic cardiomyopathy, and that's likely because of the inflammatory nature of the disease. And it's important to remember that in addition to who deserves an ICD with cardiac sarcoidosis, so in addition to the usual ICD recommendations, which is patients, who have ICDs for secondary prevention, or the primary prevention ICDs with EF less than 35%, there is a category of risk modifiers that help you decide which cardiac sarcoid patients should get an ICD. And these risk modifiers basically essentially predict a higher risk of ventricular arrhythmias and sudden death in these patients, which include syncope, extensive scar on cardiac MRI, and patients who have a permanent pacemaker. And we'll delve a little bit more into this. So why do patients who have AV block and need a permanent pacemaker also deserve an ICD instead of a pacemaker? There's data both from Japan and from Northern Europe, from Finland, that shows that in patients who present with AV block alone, without heart failure, without VT, have nearly a 10% risk of sudden death at 5 years, even with a normal EF. And that's why the recommendation for an ICD instead of a pacemaker in these patients. As far as advanced therapies go, these patients, if they end up with end-stage heart failure, they can get advanced cardiac therapies such as heart transplant or LVADs. The degree of LV dysfunction is the most important predictor of survival in these patients. And in the current era with ICD and immunosuppression, their 10-year survival is about 91%. In patients who present with LV dysfunction, their 10-year transplant-free survival is much lower, which is around 53%. With regards to LVADs, the thing to consider in this patient population is if they have RV involvement, which can cause significant RV dysfunction, if they have incessant arrhythmias, which the LVAD won't help, and then continued use of immunosuppression if they have multi-system disease, which could be a problem with a mechanical device. Post-transplant outcomes are typically have been reported to be similar as compared to transplant for other non-ischemic cardiomyopathies, and recurrence post-transplant is fairly rare. The last thing I'm going to touch upon is the confounders. I think Dr. Garcia very nicely illustrated this, where just having imaging findings does not prove that a patient has sarcoidosis, and there are several other diseases that can have similar imaging findings, such as giant cell myocarditis, other autoimmune diseases, Chagas cardiomyopathy. But in addition to that, also arrhythmogenic cardiomyopathies, DSP mutations can present with a very similar positive PET, positive MRI pattern. Lamin mutations can present in young patients with AV block, heart failure, which can be very similar to sarcoid. So going back to our patients that we discussed, so patient A, classifies as highly probable cardiac sarcoidosis because we did biopsy the lymph nodes and we did get tissue confirmation of diagnosis. This patient was started on prednisone and methotrexate. Her pacemaker was upgraded to an ICD. She did have resolution of all inflammation with prednisone and methotrexate, but as the prednisone was tapered, the inflammation came back, and that led us to escalating therapy to TNF-alpha inhibitors. Patient B, on the other hand, did not have any extra cardiac evidence of sarcoidosis after a very thorough evaluation. So that made us classify him as probable cardiac sarcoidosis based on the AHA statement, or as isolated cardiac sarcoidosis based on the Japanese criteria. Based on this, we did start him on treatment. We did repeat a PET 3 months later with no improvement in inflammation. And if that happens, it should always make you revisit the diagnosis or think about, am I treating the right disease if it's not getting better with steroids? In this case, we sent a genetic test, which we've started doing routinely now for all the isolated cardiac sarcoid patients. And we did have a pathogenic mutation in a calcium channel gene that probably explains his symptoms and allows us to come off immunosuppression. Lastly, I just want to highlight that the cardiac sarcoidosis effort here, it's a truly multidisciplinary effort. This is a multi-system disease. It's a complicated, challenging condition to treat. And it also touches many aspects of cardiology and general medicine. And we have a whole team here, a network of stakeholders that are committed to taking care of these patients. And we meet every month to discuss the complex cases and come up with the right strategy to diagnose and treat these patients. Lastly, we're also trying to contribute a little bit to improve our own understanding of the disease process. Because so little is known, particularly in our patient population, about this disease. And we're trying to evaluate the natural history, trying to look at the risk prediction for sudden cardiac death using CMR with a multi-center study, and then participating in the first and only randomized controlled trial looking at treatment strategies for cardiac sarcoidosis. Thank you. That's all I have. I'm happy to take questions.
Thank you so much, everyone. Such a comprehensive review on a really complicated topic. I just wanted to start off with a question that you touched on in Efficacy, with the role of age and the way we track response or escalation therapy. Do you routinely use PET-CT as a way to escalate therapy, and what is the recommendation on how frequently we should be doing this?
Yeah, so we do routinely use PET-CT to follow the disease response to therapy. The recommendation, if you look at the consensus statement, again, it's anywhere between 3 to 6 months. So typically, we'll start therapy. Sarcoid, in general, responds very well to steroids. The challenge usually is you cannot keep patients on high-dose steroids for a long time just because of all the side effects. We'll start with therapy. You can either start with steroids alone or combination therapy. We've increasingly started doing combination therapy up front because that allows you to come off steroids faster. Also, the other thing to realize, which I've learned mostly from the rheumatologists, is that a lot of the second-line agents take time to work. Like methotrexate takes 2 months to even work. So, if you get to the point where you've seen some response and you start taking off steroid and start a second-line agent later, it may not have enough time for the second-line agent to kick in. So what we'll do is we'll start combination therapy up front, repeat a scan in 3 months. And if there is improvement, even if there's no complete resolution, if there's improvement, we'll start coming down on the steroids, because most of our patients have diabetes, obesity, other steroid-related side effects by that point. And then once you come off steroids, we'll repeat, either you would leave them on very low dose or come off it completely and repeat a scan in 6 months as a surveillance scan to see if they're still able to maintain lack of inflammation on the PET scan. And then once, if they're totally stable, you could do it again in a year's time, or if there is a clinical change. If they get worse, if there's a clinical change, you do it again. If there's worsening on the scan after you taper steroids, then it's time to escalate therapy or go back on slightly higher dose steroids, whatever the patient will tolerate. I know that's a very complicated answer, but I think that's why it's important that these patients be treated in an environment where, they are being very carefully monitored and followed for all these complications and therapies.
You read that in the general knowledge is that biopsy was negative, cardiac biopsy, but is there higher yielding patients that have probable findings or imaging? Is there false negativity lower?
Yeah, so, if you look at the literature, I can tell you two things. One, the literature, to my experience with biopsies, endomyocardial biopsies are fairly easy to do, and we've done them a bunch in patients early on, but the yield has been RV endomyocardial biopsies. The yield has been, you just have to get lucky to get a diagnosis. It's very rare that you see a positive RV endomyocardial biopsy. If you do use the PET MRI, and the last thing is electroanatomic mapping, which also we've done a few times since I've started. The yield, even with that, has been very, very dismal. The yield for me literally has been 0. Now, there's several reasons for that. One is even with the voltage map, you're trying to get to these areas which are peri-scar. So you see scar with the low voltage and you try to get to the peri-scar areas. It's hard. You don't know what you're really getting. You're taking your best guess. And a lot of the disease, if you see on MRI, is mid-myocardial and sub-epicardial, right? So most of what you're biopsying when you do the biopsy is endocardium. So that may be part of the reason why the yield is low. I think, the literature says that the yield's 20% if you do an RV endomyocardial biopsy. And if you use imaging and electroanatomic mapping, it goes up to 40 to 50%. That has not been my experience at all over the last 4 years. But I have also in other sarcoid forums with experts discussed this, and their clinical experience has been the same as mine. So everybody has stopped doing biopsies for that very reason.
Okay, thank you so much. Once again, very attentive to the audience. We're going to move on to the next.
Okay, let's just dive right in because I got lunch for you guys to get to here. I'm going to talk about the diagnosis and treatment of hypertrophic obstructive cardiomyopathy along with Dr. Scanoni, who's the director of our clinic here. And it's a bad time when I think of this as the least confusing topic of all the things that we've heard. Okay, so first we'll start off with a case presentation. This is a 66-year-old female I saw maybe a year ago. She's coming in for the evaluation of shortness of breath. She just has a history of hypertension, but well controlled on diltiazem. And she's quite an active woman, and she noticed that she's more short of breath during her CrossFit classes, which is pretty extreme exercise here. So really not an overt limitation, but she's noticing a difference. Family history is notable for not having any history of sudden cardiac death, no early cardiac disease, and she has 2 healthy children. I'm going to move on to the baseline EKG, which has, relatively bland. We can say there's some LVH changes here, but otherwise, and perhaps some repolarization abnormalities in the lateral leads here, but nothing to write home about. Okay, and I'm going to switch over to Dr. Scanoni to talk about the imaging.
Sure, thank you, Sandhya. So I think the first thing that I want to highlight, this is the patient gets an echocardiography, and clearly we can see that there's asymmetric septal thickness. One thing that I really want to emphasize with this picture is that it's very, very important that we avoid measuring the RV trabecula. And that's something that in clinical practice we see often. And that can have diagnostic, of course, but also prognostic implication if you measure all to 28 millimeters. So be careful with that. When you see the rest of the echo, you can see that there's definitely, mitral valve systolic anterior motion. But I think we have to go beyond that. Why is my patient having a systolic anterior motion? And in this particular case, you can see that the anterior leaflet of the mitral valve is very elongated, and that could be a big factor in addition to the hypercontractility that we're going to talk a little more about that, how we can deal with that. And finally, on the color Doppler, or the stop right for a second, I think you can really identify where is actually the level of flow acceleration, and that can be very important for patients that are more challenging, like those that maybe have an intracavitary plus LVOT plus aortic stenosis. So how you define what's the level. And often we can see there's a multi-level obstruction that makes it very difficult. So the color Doppler can also help you in identifying that, in addition to detecting mitral regurgitation. So in this particular patient, on resting picture was sent for, with the Doppler across the LVOT, and we didn't necessarily elicit a significant gradient through the LVOT with a resting gradient of 60 millimeters of mercury, even with Valsalva. So with that, I'm just going to switch back to.
Okay, so let's go to our first audience response question. Does this patient have obstructive cardiomyopathy? Yes, because the septum is greater than 15. No, because there's no obstruction at rest. Can't tell because you need genetic studies or you need more imaging. Give you guys a second. For responses. All right, need more imaging. Great. So we'll talk through each of these, but that is the correct answer.
Yeah, I think we can stop here and just move on. I think you guys nailed it.
We're done. Okay, so a little bit background about hypertrophic cardiomyopathy in general. It's getting to be more and more common than we thought. And part of that is, well, most of that is really just to imaging and awareness and the sophistication of our imaging techniques. We have a prevalence map here. In red, you can see all the countries with a higher prevalence. We're up to about 200 to 500 people. You know, one in every 200 to 500 people will carry this mutation, carry this disease. About 20 million people are affected worldwide. In the United States alone, 750,000 people. And this is just what we know about it. On this pie chart here, you can see that most of our cases are presumably unidentified, and we have about half symptomatic, half asymptomatic clinically identified cases. So this is always our goal of initial presentation, to figure out what is the phenotype, what is the natural history, what can we tell this patient about risk. So I want to just point out that for the vast majority of patients, for the majority of patients, just nearly 50-50 actually, there's no adverse outcomes that happens with hypertrophic cardiomyopathy. These are the three phenotypes that we can see with the symptomatic patients. We have the progressive heart failure group, which most of those are going to be the obstructive phenotype. We have atrial fibrillation, which can happen across the board, about 17%. And this is really the phenotype that we are most interested in finding. These are the sudden cardiac death patients, about 6% of patients with HCM. So what have we learned over the past few years is that there are some major markers of risk we can use to predict who is going to have one of these events. So family history, unexplained syncope, and of course, NSVT or VT on monitor. LV apical aneurysm has been associated with sudden death. Massive LVH, greater than 30%, and then extensive LGE as defined by over 15% on MRI. We'll talk a little bit more about that. Or end-stage heart failure with an EF under 50%. So something to point out is that the lower risk age is actually greater than 60. So if you have a 65, 70-year-old in the clinic, you can say that, you know what, your risk of sudden death is low. And that's really important because with the use of our ICDs over the past 20 years, there's been a 10-fold decrease in disease-related mortality. So this is really important to find this group of patients who you think would benefit from an ICD and translate to lives saved.
Okay, so I guess we can start how we navigate the diagnosis, which is the most challenging part of hypertrophic cardiomyopathy. I think the very first thing that I want to say, hypertrophic cardiomyopathy is a clinical diagnosis. It's not an imaging diagnosis. And we have touched upon these in the different diseases that we have reviewed. I think you need to incorporate the family history, the clinical presentation, of course, the imaging findings, including the ECG, and often enough, your genetic testing. And you have to exclude, mimickers that could create that wall thickness. That's very, very important. So I agree with you guys that just because the echo showed these features, you cannot just go and jump and say this is hypertrophic cardiomyopathy right away. So the way I see the diagnosis of hypertrophic cardiomyopathy and the use of imaging is in kind of phases. I think in phase one, you want to try to aid the diagnosis. Again, I'm not saying make the diagnosis, just aid the diagnosis and exclude mimickers or phencopies. Once you do that, you go to the phase two, which is more about how you phenotype and characterize your hypertrophic cardiomyopathy patient. What are the disease mechanisms that I can act upon? I need to prognosticate and make a decision on ICD or not. And finally, hopefully, we can use imaging to assess response to therapy. So this is what the most recent guidelines, which are published like a couple of weeks ago, say, with some kind of suggestions you can see in gray from me. I mean, when you do echo, we know that in every patient that we have a suspicion for it, you're going to do echo to look for LVOT obstruction, either at rest or with stress. And you can use contrast if you're, of course, not seeing the cavity well, but also if you have concern for apical hypertrophic cardiomyopathy, if you're concerned about apical aneurysm, or you have an atypical pattern. I would say that if you're thinking in apical hypertrophic cardiomyopathy, probably all of these patients should have echo with contrast. Now, the use of MRI, I think in my mind is complementary. I would say virtually all patients benefit from this unless it's a very slam dunk. Someone has a family history with gene positive, and has like the typical features. I think most likely this is hypertrophic cardiomyopathy and already had like sudden death in the family. So you don't need prognostication. ICD is already indicated. But except that particular scenario, I think you're going to need a cardiac MRI in every patient to exclude mimickers, assess LGE burden to make decisions on ICD, and sometimes can give you an idea of what's the mechanism of obstruction. So again, we have to identify why my patient is having SAM and LVOT obstruction, particularly in cases that we're sending for surgery. Now, the use of cardiac CT and nuclear stress test is less highlighted in the guidelines. We can use definitely cardiac CT with contrast to see the hypertrophy. I mean, we can see that very easily. But I would argue that if you're thinking, a patient with hypertrophic cardiomyopathy can have atherosclerosis, and if you have someone who comes in with chest pain and you have a legit question about obstructive CAD, I would suggest that coronary CTA is the right test to do. Many of these patients have macrovascular dysfunction. So if you do a stress test, you're not sure if this is actually a macrovascular versus an epicardial. So I think the first test, to look into this patient is actually a coronary CTA or left coronary angiogram if you cannot do that. In terms of the nuclear stress test on the other side, you have the scenario in which the patient has symptoms, chest pain, there's no obstructive CAD, there's no LVOT obstruction. So why my patient having symptoms, shortness of breath and chest pain? So maybe you have microvascular dysfunction and microvascular angina, and nuclear can really help you here. So what are the main features? And we touched upon about this a few seconds ago. I mean, the first thing is the asymmetric hypertrophy that could be anywhere in the ventricle, and these are the criteria that are very well established in the guidelines. The presence of SAM and LVOT obstruction is something that often we see. Up to 70% of patients with septal hypertrophic cardiomyopathy can have it. And of course, the typical patchy mid-myocardial leg ligament enhancement, which is a surrogate for replacement fibrosis that we can see in up to 50% of patients. But this is the important thing. These features in isolation do not diagnose hypertrophic cardiomyopathy. You need to go back to your patient, your clinic, your history, and so on to put it together. So one thing that also in the other side of the spectrum we need to be very careful is that we are kind of working on the assumption of the 1.5 centimeter or more, or 1.3 with the genetic positive and so on. But be careful with the apical, because you have to be looking at the ECG. You have to be looking at that, incorrect or not normal tapering of the ventricle. Usually the ventricle should start tapering from base to apex. In patients with apical hypertrophic cardiomyopathy, you lose that. So now the apex looks a little thicker than the base. And even if you don't have more than 1.5 centimeter, that can be signs of hypertrophic cardiomyopathy in the apical variant. And then if you use that index by body surface area, and this is the number in the most recent paper that came out, you can improve your diagnostic certainty and sensitivity and specificity for the detection of apical hypertrophic cardiomyopathy. So be careful with that criteria in apical and just look more than just the thickness. The other thing that is important to acknowledge is that, again, the presence of septal thickness and LVOT obstruction, again, do not secure the diagnosis. This is a study on a large series of patients that were referred for myomectomy for LVOT obstruction with septal hypertrophy. And then up to 1 out of 5 of these patients had an alternative diagnosis. That could be amyloid, could be, could be Fabry's cardiomyopathy, could be hypertensive heart disease. So be aware of the phenocopies, and MRI can really help you here.
So this is how, MRI can really help you differentiate between the different phenocopys. You can see how hypertrophic cardiomyopathy looks like on the left and how hypertensive amyloid, fibrils, and danos can see in the different columns. And they have very distinct phenotypes. So use your imaging team to help you manage these patients. So not all the hypertrophic cardiomyopathies are the same. Some of them are more sigmoid with less genetic testing positive and more LVOT, all the way to apical hypertrophic cardiomyopathy, which has been quoted as a more favorable phenotype. We're learning more and more about these, and might be not necessarily totally true. So you have to characterize it and phenotype it. So look for LVOT obstruction. So if your patient doesn't have LVOT obstruction and SAM at rest, you really need to look for it. So your patient can present as a non-obstructive, as a latent obstructive, meaning you have no obstruction at rest, and obstruction means grading across the LVOT of more than 30 millimeters of mercury. But when you exercise them, they actually develop the LVOT obstruction. So it's important that we look for these because 70% of patients do have it. Always be in the look for alternative mechanisms of LVOT obstruction, particularly if you're going to send the patient for surgery. Traditionally, we thought about the pushing and the pulling forces and the LVOT, the septal thickness and so on. But then there are other features that can cause these. Papillary muscles abnormalities, elongated mitral leaflet, abnormal choroid insertions. And those are things that if you don't identify a priori in patients that are going for myomectomy or septal reduction therapies, and you don't fix those, you might not end up with a good result. So look for the obstruction without the age. So those factors are kind of very important. Always look for alternative mechanisms of symptoms. I mean, my patient with symptoms is not always just related to LVOT obstruction. You can have systolic and diastolic dysfunction. You can have mitral regurgitation, or if you can have myocardial ischemia from either epicardial or microvascular disease. You can see how imaging can help you there. So again, similar symptoms might have different mechanisms, and it's for you to detect. And finally, imaging can also be important in pre-certification. And here are kind of the different features that imaging can really be of help, from EF, wall thickness, scar burden, and the presence of apical aneurysm. This is going back to our patient. We can definitely see that there's a asymmetric septal thickening, which is up to 18 millimeters. There's patchy LGE, which is less than 1%, not that high. And then we have in the CNA images, there's systolic anterior motion suggestive of LVOT obstruction. Now we can say that this is most likely, with the clinical history, hypertrophic cardiomyopathy with obstruction. The patient was sent for stress echo to try to understand why the patient is dyspneic. And here, this is what we get. I just want to emphasize here, this is typical thing we see in clinical practice. On your left, you see this kind of more rounded jet, as opposed to a more dagger shape on the right. So don't be confused. The one on the left is just mitral contamination. That's not LVOT gradient. The typical LVOT gradient is the one that you have on your right. In this particular patient, it was up to 100 millimeters of mercury with exercise, explaining the patient's symptoms.
Okay, I'm pretty convinced. So there's obstruction. This is our patient with now obstructive hypertrophic cardiomyopathy. Her heart rate is 55. Remember, she's on diltiazem for blood pressure. Now what do we do? Do we refer for surgical myectomy, start disopyramide, send her for alcohol septal ablation, or start myosin inhibitor therapy? Okay. Okay. There's some consensus among the audience that we would initiate myosin inhibitor therapy. So I'm happy to hear that, but let's go through some of the data here. Okay. So we have 3 different treatment strategies here. One is medical therapy, and first-line therapy is always AV nodal blocking agents, either diltiazem, metoprolol. That's always going to be your first line defense.
Next, we have the so-called septal reduction therapies, which include surgical myectomy, excuse me, or alcohol septal ablation. So just a word on the surgical option. In very experienced centers, the mortality rate is about 3%, but that also carries a 10% heart block rate. Okay, so although this is a definitive treatment for HOCM, there is a significant need for morbidity after bypass, et cetera. Versus alcohol septal ablation, which the only caveat to this is that you really have to have the right anatomy for this. And in well-experienced centers, the mortality is less than 1%, and this is all done in the cath lab. So we have kind of a slew of options. Now let's talk about the newest kind of kid on the block, which is actually now about 2 years old. We have mavacamten, which is first in class. This is a myosin inhibitor. And I just want to briefly describe normal physiology in the cardiac muscle. So we have these thin actin filaments, we have these thick myosin filaments, and in between them are these actin-myosin cross bridges. In a normal myocardium, you have most of these actin-myosin cross bridges are in the deactivated position. And just an occasional few are in the activated position. And once you're activated, that's kind of you want to think about it as a tight muscle. Look at HCM sarcomere. Now you see that there's definitely an abundance of activated actin-myosin cross bridges. And then, put this patient on mavacamten, we look at these histology samples, and we see that there's less cross links of the actin and myosin cross bridge. So that's kind of the pathophysiology, and you can kind of think of it as attenuated hypercontractility, and in this in turn will improve energetics, less myocardial oxygen is used, and improve the myocardial efficiency and turn it into more of a normal appearing sarcomere. So let's look at the trial data. We have 3 major phase 3 randomized controlled trials for this, and basically I want to point out a couple of highlights here. So the adverse events of interest are a decrease in LVEF. And why is that? Well, it relaxes the myocardium. If you delink these actin and myosin bridges too much, you're going to get the opposite, which is a low EF. So across the board in these trials, there was a percentage of patients that had that decrease in LVEF. Now, these were all, recovered and reversible changes, but this is something that is a point of interest, especially when you think about it's not just a pill. We have to be aware that you may be creating heart failure in our patients by giving them these potent negative kind of inotropes. So the one thing I will say is that with the 62-week follow-up of the Explorer trial, which is one of the larger trials, is that there was 8 episodes of heart failure, all reversed, and 21 that had AF. But with the 62 weeks of follow-up here, we see that the benefit was sustained throughout all this time. So that although this is a very kind of point of interest that we always want to be aware of, there was sustained benefit and always a reversible component to this. The Valor trial was interesting because it compared mavacamten use to septal reduction therapy, meaning that all patients were septal reduction therapy candidates, either surgical or alcohol septal ablation. And the endpoint was really the decision to proceed with SRT after mavacamten use. And so what they found is that 18% at the end of 16 weeks were eligible still for SRT, versus 77% in the placebo, who basically would have benefited from SRT at the end of the study period. So I highlight this just to say that Dr. Latib's job is not done. There's still 18%, even after mavacamten use, that would opt or would still be candidates for SRT. Now, they did a 56-week extension of that, and it turns out that at 56 weeks, 90% of the patients who are on mavacamten elected to stay on mavacamten, and at the end of 56 weeks, only 9 met SRT criteria. So this, in a way, is a viable option to any interventional or surgical approach. And I want to talk a little bit about our experience. We started 2 years ago prescribing mavacamten. We have about 30 patients on mavacamten. And the first thing to know is that because of that LVEF drop, the FDA mandates that we do monthly echocardiograms for the first 3 months. This is a lot of echocardiograms. So we're doing 90 echocardiograms on these 30 patients. And then after that, every 3 months. And that's assuming we don't change the dose. If we change the dose, you're doing monthly echocardiograms for the first 6 months, more or less. So this is a very time consuming, this is very involved. You need a lot of support to do this and to kind of coordinate this. And the company, the specialty pharmacies won't even release dose unless you show that you've done this echo and you've uploaded the data. It is a lot of work. So I have to say that only one patient out of these 30 patients over the last 2 years have required interruption of therapy, and that was an LVEF drop to 48%. So anything under 50%, we have to interrupt therapy. 60% of our patients required a dose adjustment in the first 3 months, and usually that's dose down. We try to get them on the minimum dose necessary. But that being said, then we repeat our 3-month monthly echo thing. So just to point out that this is a very time-consuming process. Average baseline Valsalva gradient was 82 in our group, and it went down to 30 at the end of a 3-month period. So in 3 months, we're able to significantly improve the obstruction. And our longest experience now is about 2 years, and patients are maintained on the lowest dose of mavacamten. And again, only one patient has required interruption of therapy and eventually went back on therapy when the LVEF recovered, which the time to that is about 2 weeks or so. Finally, I want to just talk a bit on exercise recommendations. This is a very kind of controversial topic out there. These are two kind of contradictory and almost, to look at these side by side is really compelling. The first pie graph here shows you the causes of sudden cardiac death in young athletes. And by and large, you see the majority is going to be hypertrophic cardiomyopathy. And then there's 8% that's possible HCM. So this is really the bulk of the cases that we see and we hear on TV of these basketball players, football players dropping dead and having to be resuscitated. The 2024 guidelines, which again, as Aldo mentioned, came out a few weeks ago, has basically a very kind of mutual shared decision-making aspect when it comes to exercise. They have not, they've come out with saying that there is really no reason to counsel our patients to not do competitive sports, although the European guidelines would disagree with that and say that the finding of hypertrophic cardiomyopathy in young competitive athletes should be an exclusion, meaning that they shouldn't be allowed to play, whereas the American Society guidelines have taken more of a joint decision-making approach to that. So that's still a very kind of controversial topic out there. And keeping in mind that our patient is a avid CrossFit lady. So that being said, I wanted to kind of wrap up with, we talked a lot about obstructive mavacamten. There's a lot coming down the pike. For the future, we have the phase 3 trial for aficamten that was just completed and published. This is the phase 3 trial. So the benefit of aficamten and kind of the edge that this has is that it's a much shorter half-life, which will allow for dose adjustments every 2 weeks. And what that means is that there's a shallower dose response, which allow for smaller reductions in LVEF. And there's a wide therapeutic window of this. And the point of this is that hopefully with this kind of shallow therapeutic, this wide therapeutic window, you shouldn't see that drop in EF. And it was a very low incidence of this in this trial, about 3%, compared to about 7 to 10% in the prior generation. So, and again, equivalent data is a fantastic drop in LV outflow tract gradients and quality of life in patients. All right, so what about the non-obstructive phenotypes? Because we talked about a lot about the obstructions, but the non-obstructive is still about half the HCM patients out there. So this is a very interesting molecule. It's a part of the drug class known as cardiac mitogen. So basically what this does is it converts the metabolism, the energy metabolism from fatty acid metabolism to glucose metabolism. It blocks fatty acid metabolism. It's a partial inhibitor. So what that does is it makes the myocardium a lot more effective in energy utilization. You get a lot more ATP out of glucose metabolism. And this is currently in phase 2 trials. So we'll look forward to that. And we think about these non-obstructive hearts as being constantly energy deplete. So this is supposed to address some of the cardiac energetics behind the disease. Now, a very kind of hot topic here, we've heard it several times about CRISPR technology. So what we're doing now, and this is in phase 1b trial, this is looking at a particular gene mutation, one of the 2 most common gene mutations seen in HCM. It's the MYBPC3 gene mutation, using an adenovirus-based delivery of the working gene to the heart using CRISPR technology. It's currently in trials, and this would be, this is very exciting, obviously, stuff, but we're still many years away from having some data about this. What about our patient? So our patient at the end of the 3-month period, she was also MYBPC mutation positive, had a Valsalva gradient negligible, about 2.5, so roughly about 30, just as what we've seen in our trial. So very effective therapy in a very short amount of time, requires a constant follow-up, but may preclude the need for any kind of septal reduction consideration. And this is kind of the layout. We've talked about most of these things, about what's been happening in HCM for the last 20 years, and a lot of things to look forward to on the right here. We have aficamten coming up as the next in line. The non-ischemic, the non-hyper obstructive phenotype is getting a lot of scientific research now, and not even stepping beyond that, the non-obstructive phenotype, relaying that to diastolic heart failure. There's a lot of stuff happening here where there's similar pathophysiologies. Myocardial energetics we talked about, and then there's also less invasive SRT techniques as far as reducing the septum, not less invasively, obviating the need for surgery. So, and then gene therapy, which everyone's very excited about. So this is really in the last 20 years. And with that, I'm going to end 12:17. Hopefully, grab some lunch and hit the talk on amyloid silencers.
Yes, absolutely. Absolutely.
Anyone who wants to stick around for questions, more than welcome to for a couple of minutes.
I don't know if you got it, but there's this another country removed the substitute for ICD,
yeah.
And the second question, what happens when the infection can be used when it occurs in the patient? Are you starting your heart failure treatment medications, and when do you go back to again?
Yeah, so great question. So
and one more question. How is this better than surgical septal resection? Because that is one time done, and where it is ongoing forever.
Yep, therein lies the point that this is 2 years of data, 2 years of data with mavacamten, real world data. So to address some of your points, it usually is around 2 weeks or so we see the LV recover. It's a reversible phenomenon. We never use GDMT because it does recover. We follow up with an echo at 1 month. And usually if, with shared decision making, we restart the mavacamten, it would be at a lower dose, and we do the same process again. It had, thankfully, we have not seen any low LVEFs that have required hospitalization. We're probably because we're checking echoes so frequently that we're not waiting until it's 30%, 48% we stop, So and how is it better? It's a pill. It's not an invasive procedure. That is really it, And with these newer generations with aficamten, we're going to see even less and less of the LV reduction. I think you offer a patient a procedure, interventional procedure versus a surgery versus a pill, people will opt to take the pill. And again, that's kind of what the VALOR trial showed us, that at the end of the study period, only about 8% were still candidates for septal reduction therapy. And most patients opted to stay on the pill rather than the one, big surgery. And I think that was the bulk of your questions.
Great talks. Quick question. I think
Oakley is doing a pathological diagnosis. Why don't we biopsy these patients?
I think it's a good point. Aldo, any thoughts on biopsy?
I mean, the issue is that, I mean, you can start looking at the disarray, but still, like, that's not necessarily, you know, even though we see it, not enough to just say the diagnosis. You still need to go back to the integration, which is what makes this very difficult.
Yeah.
I mean, if you have a patient who, again, we have done this in few instances where, I mean, there's some atypical features and you're still confused between the imaging and the clinical presentation, and you go for biopsy primarily to exclude phencopies. Because, you know, from an amyloid perspective, let me just get onto that point. I mean, sometimes the imaging can let you down. You still have amyloid. So sometimes you're still in the question, is this still amyloid? Because you would really want to treat it right? You go for biopsy. And then if you exclude the other phencopies and you see that there's kind of disarray and a little fibrosis, then that can help you guide you in the right direction. But I think that's kind of probably as a last resort in selected cases.
I just had a common question. I mean, there's a little bit of a paradox in the way that the drug actually works, right? So you mentioned how that by decreasing the bridge between actin and myosin, it decreases contractility, right? But if you look at the hypertrophic segment, either on biopsy, they're fiber disarray. If you do echo, you see that they are actually low strain, they have low contractility to begin with. So does it work by lowering contractility in those segments or in the rest of the myocardium?
Yeah, I think that's a very interesting and insightful question. I think to answer that, we have to go back to the actual pathophysiology of hypertrophic cardiomyopathy. And arguably, there's some studies that suggest that, you know, the combination of hypercontractility and energy deficiency or abnormal energetics are kind of the initiation of the pathophysiology that leads then to hypertrophy. And that's something that can be compared to some of the mitochondrial diseases, that actually the energy deprivation is what then leads to the hypertrophy. So I think hypertrophic cardiomyopathy starts somewhere with the pathophysiology of the increased cross bridges and energy deficiency that then led to the hypertrophy. So I think to your point, I think where you're acting upon is in some of the other segments of the ventricle that are not hypertrophy yet, to try to prevent the contractility that leads to the progression of perhaps a disease. We don't know that, but you know, that's something that we're kind of really interested into looking at. Once you have the hypertrophy segment that is all scored out, then I think it's very hard. That's probably kind of towards the end of the spectrum of the disease. So it will be very, very interesting to do some work. And you know, I think it's coming to see as you go earlier and earlier in the disease process and what happened to these patients.
Oh, sorry, Francis' question.
Just yell, we'll repeat it.
Recommended that these patients exercise at all. So if they do exercise and you're recommending moderate intensity exercise, how is this exactly quantified? Are they wearing heart rate monitors to say, hey, you don't go past zone 2 or?
Yeah, no, it's you know, short of competitive sports, all stages of exercise are permitted, you know, or thought to be beneficial for patients. So while we don't quantify, you know, hopefully you've done your sudden cardiac death risk assessment, you know, exercise, NSVT, and, you know, this is a low risk, you know, for sudden cardiac death patient. The official word on exercise is moderate, as short of competitive sports, enjoy.
So you can go to Orange Theory.
Orange Theory. Orange Theory is permitted.
Yeah, what I would add on that is if you see the chart here on the recent guidelines, I think for any mild to moderate recreational, I think it's a class 1. And I think that's a very important topic. And that's what the guidelines are trying to get at, is that, you know, if you restrict activity, I mean, these patients are not exempt from CAD, diabetes, and these patients get a lot of this, right? So by, you know, restricting any kind of exercise, you're worse, right? So I think when you get to the point that, I mean, if patients kind of walking or moving or everything, it's just very light. I think if you're going to get more into the more intense,
I think that's a sign.
Yeah. If you want to get into the yellow zone, it has a shared decision, right? So you get your center of excellence, and then you can make a decision together. You have a stress echo data, so you can see how the patient develop in the careful setting, and just make together that decision. The same for like athletes.
But he was asking an interesting question is because of the ascendance of remote monitoring. Will it be beneficial to have either pressure monitor versus with them to have EKG monitor with the transmission of the data? So if that will make you feel more comfortable with the patient who are exercising and they don't have clear stress EKG.
So you're talking about, the question is like having remote monitoring during the exercise.
Yeah.
I mean, I think there's no data there. I think in my practice, if the patient is fit and can exercise and performs very well on the stress echo, and then you can do even kind of CPAP, I think that for me is enough based on the rest of the risk assessment. I don't think you need to get into kind of continuous monitoring of these patients, because then that introduces on the other side of the spectrum an issue, right? Because then some of these non-sustained VT happen quite frequently, and then all people gets really panic about like few bits and get ICD, restrict stuff. So have to be careful about how you analyze and utilize, a lot of data. That I think at this point, I don't think there's any evidence to support that.
I'm out. This was really terrific. Great session. I'm very proud of the team. You set the bar high for the next session. We'll break now. We'll have lunch. We will start 15 minutes late at 1:15. And there is now a special session on gene silencers and amyloid. If you're interested, it should be very good. I would say they probably start in about 15-20 minutes in one of the conference rooms next to the exhibit. You should try to go there.
Good night.
Who is that? No, well. Okay.
We have more than 30 patients.